Hello everyone, welcome to the INI-CET November 2023 recall. I am Dr. Harmeet Goyal, your Obs Gynae faculty at LN. Next, I am taking up a gynecology recall. Hope you must have done the paper well and welcome to this recall session. So, the first question in the gynecology that came was HPV vaccine component is derived from which viral protein? So, the options given to me are L1, E1 plus E2, L2, E6 and E7. Now, what all have you marked the answers? Which answer you have marked? Is it L1? Is it L2, E1, E2 or E6, E7? I am seeing your live chat. You can write down your answers in the chat box. So, the answer is L1. Most of you are correct. The viral capsid protein from where the HPV vaccine is been made is L1 protein. Now, the HPV virus is a DNA virus and it uses the host immunity for viral replication, but simultaneously it is responsible for some changes in the cell so that there is dysplastic changes in the cell and later on it can change into dysplasia, that is a precancerous condition, and then that can later on develop into cancer cervix. So, the DNA virus uses the cell machinery. So, it has got E1, E2, E6, E7, L1, L2 capsid proteins. Now, when HPV infection occurs, so the age group in which the HPV infection is very prevalent once the female is sexually active, that is 20 to 30 years of age. Now, most of the time our body immunity clears out that infection, but in very less cases when it persists, it can cause like persistent infection when the DNA of the virus integrates into the host DNA and the replication of viral oncoproteins take place. This leads to dysplasia. So, E1 and E2 viral proteins are responsible for replication of the virus. This is again an important question, and E6, E7 are responsible for malignant transformation that is causing the dysplastic changes. Now, HPV virus, like E genes are expressed in basal and parabasal layer while L genes are expressed in the superficial layers. So, this is the reason why the L1 capsid protein is being used, while the HPV vaccine is being prepared. So, E1, E2 are responsible for viral replication, E6, E7 are responsible for malignant transformation, and L1 is responsible because it is present in the superficial layers. So, this is the protein where the vaccine is being prepared. Now, this I have just now explained that. Can you see this image where like E1, E2, E6, E7 viral proteins are in the basal or parabasal layer, whereas the L1, L2, L3 proteins, viral capsid proteins are in the superficial layers. So, from these superficial layers, these proteins can be used and it can be used for making up the vaccine. Now, HPV subtypes, it can be the low risk subtypes or high risk subtypes. Low risk subtypes are HPV 6 and 11, which are responsible for genital warts and condyloma formation, whereas HPV 16, 18, 31, 33, 45, 52, 58 are the high oncogenic potential virus strains, which are the risk for cancer cervix, vulval and vaginal cancer in the females, and in the males it can be the penile cancer, oropharyngeal and anorectal cancers. Now, in cancer cervix, it has a proven role that HPV infection is a cause or risk factor for cancer cervix. Now, why we talk about vaccination? Because when we vaccinate the girls, that is on the lowermost stair of this pyramid, so we can do the protection against this HPV infection, and like cancer cervix can be 100% preventable. Now, why we talk about the cancer cervix? Why? Because it is very, very unique. This is the only cancer where we know the causative agent HPV virus 1618. This is the only cancer where the vaccine is available, and this is the only cancer where WHO claims to eradicate by the vaccination of the girls. 90% girls should be vaccinated, 70% of the females should be screened, and 90% of the females should get the detection and treatment. That's how the eradication of the cancer cervix can be done. But in India, it is just less than 2% girls are vaccinated, and less than 1 to 2% females are being screened. So we are we have a long journey to follow to eradicate the cancer cervix. Now, vaccine is Gardasil vaccine, which is a quadrivalent vaccine. Quadrivalent vaccine that is against HPV 6, 11, 16, 18. Okay, it is to be given in the deltoid region. Now, age group for vaccination according to WHO is 9 to 26 years. Ideal age group is 11 to 12 years. Why we talk about the ideal age group? Because this is the age group where the immune response to antigen is very, very good. Now, according to FDA, the age group is 9 to 45 years, but it's always better that once the female is sexually active or she gets married, before that the vaccination should be done. So, according to WHO, the age group for vaccination is 9 to 26 years, ideal is 11 to 12 years. But according to FDA, they say 9 to 45 years. Now, dosage schedule in less than 15 years, it is, you can say 9 to 14 years, it is 2 doses, 0 and 6 months, 2 dosage, and after 15 years it is 0, 2 and 6 months. That is the dosage schedule. Now, HPV vaccines are highly immunogenic. It is prepared from viral L1 capsid protein. This is a repeat question and we have been discussing in our classes. And immunity develops against to prevent the viral entry into the epithelial cells. So, that is what is important. Now, the cancer cervix eradication is 90% vaccination, 70% screening, and 90% should get the treatment. Next question, 65-year-old women report shows epithelial ovarian tumor with peritoneal metastasis and ascites. What is the treatment? Now, peritoneal metastasis is always considered as stage 3, which is advanced cancer. Now, what is the management in this case? What is the management? In this case, management in this case will be, the options given to me are radiotherapy followed by debulking, chemotherapy, debulking followed by chemotherapy. So, what is the correct option? What is the correct option? Now, always when we talk about advanced ovarian cancers, one thing you already know that we do the surgical staging. We go for the surgical staging in ovarian cancer. Okay, I will be just explaining the surgical staging. Now, in advanced cancers, apart from doing surgical staging, taking the biopsies, doing total abdominal hysterectomy with bilateral salpingo-oophorectomy, with pelvic lymph node removal and para-aortic lymph node removal, in addition, we have to go for, like the omentectomy, hemicolectomies, etc. But when we talk about the advanced cancers, that is debulking surgery or cytoreductive surgery. Another name for debulking surgery is cytoreductive surgery. Cytoreductive surgery. So, the correct answer here will be debulking followed by chemotherapy. therapy, because when you're doing a cytoreductive surgery, as much as the tumor mass you are taking it out, whichever structures are involved you are taking it out, then it is not a guarantee that even a single cancer cell is being removed. So post-operative chemotherapy is must. Now we look at the staging part. As I mentioned, for the peritoneal metastasis, it is already considered as stage 3B, which is advanced cancer ovary. Now surgical staging, we go for a midline laparotomy and we collect if any ascitic fluid is present and send it for frozen section. Any ascitic fluid present and send it for frozen section. Then we do the inspection and palpation of the abdominal organs, random peritoneal biopsies, hysterectomy followed by lymphadenectomy. Okay, and when we talk about the advanced cancers, we have to go for a debulking or cytoreductive surgery in this case. So debulking surgery followed by chemotherapy. Chemotherapeutic drugs we use is carboplatin and paclitaxel in different cycles. Next question. Slide for screening of cancer cervix. Sample shows blue color dye. Now why is this blue color and what is the stain used in this case? Stain used in this case, is it a toluidine blue? Is it a toluidine blue? Is it a Lugol's iodine? Is it Papineau-Collet stain or dye? So the correct answer is, it is the Pap smear stain, that is called as Papineau-Collet stain, which is staining the cell's nucleus as blue. So Papineau-Collet stain is a multichromatotic multicolored cytological staining technique. It has been used for a cytological testing and it has been used to stain the other smears as well. So it is developed by George Papineau-Collet in 1942. One of the exam question, the image of this person and this man was also been asked in one of the exam questions. Now this is the slides, Pap smear slides. So Pap smear can be done by the two methods. One is a conventional method where we take two smears. One is with the Ayers spatula, one is with the Ayers spatula, wooden spatula, we take it from the actocervix, and another one is a cytobrush and we take the smear and we make this smear on the slides and we fix it with a cytospray. Okay, so smear number 1 and smear number 2, we fix it with a cytospray which contains 95% ethanol plus ether. So this is a conventional Pap smear. Now this is a liquid based cytology where we use this spatula to take the smear and we put it in this bottle which is already containing a fixative. That fixative is a methanol. Okay, and then we send it for the microscopic examination. This is the conventional Pap slide and this is the liquid based cytology. So liquid based cytology is a step ahead and the cell cytology is visualized very clearly in that case. Now this is a normal smear, this is mild dysplasia and this is severe dysplasia. In cases of severe dysplasia, if you take the colposcopic directed cervical biopsy, you will see that the complete epithelial cells are containing dysplastic cells, but the important feature is the basement membrane is intact. So the whole epithelium contains dysplastic cells. That means the nucleus and cytoplasmic ratio has become altered. There is increased mitotic figures. That is what is a dysplastic changes. And when it is involving the complete epithelium, we call it as severe dysplasia. So Pap smear is to be started in 21 year of aged female who is sexually active, and it should be repeated every 3 yearly till her age is 30 years, then every 5 yearly along with HPV DNA test. If you want to repeat the pap smear 5 yearly, then you have to do HPV DNA testing along with that, and this should be done every 5 yearly. What is the age group to start HPV DNA testing? It should be started from 30 years of age. So you do it along with pap smear every 5 yearly till her age is 60 to 65 and then stop. If suppose the lady cannot afford the HPV DNA testing or the facility is not available, then you can do pap smear every 3 yearly. But mind it, nowadays according to the WHO, in high resource countries, like the best screening tool they say is HPV DNA. The best screening tool is HPV DNA, and this is the best answer for screening against dysplasia or cancer cervix, doing the HPV DNA testing. Now students get confused that it is to be taken from blood. That is a wrong answer. Like we are taking a pap smear from the cervix, so similarly the sample is taken like the liquid based cytology we are taking. Like I am working in a Cancer Institute of Delhi, one of the reputed cancer institute. So what we are doing is we are taking up the pap smear, that is a liquid based cytology, and like the same sample we are sending is for HPV DNA testing. Okay, so HPV DNA testing is the best screening tool when it is a resource rich countries. Okay, so what are the screening methods? Screening methods are HPV DNA, or it can be done HPV DNA along with pap smear, that is a co-testing, or it can be done just the pap smear, or it is VIA, visual inspection under acetic acid. So triage tool includes the questions being asked on the triage tool as well, where there is a cytology, HPV DNA testing and VIA, and there is a facilities for colposcopic directed cervical biopsy. If there is any CIN2 or CIN3 finding coming, that is HCIL is coming, then we should go for a colposcopy, and if the colposcopic directed biopsy is also showing CIN2 or CIN3, then we have to go for ablation procedure, and the best ablation procedure for CIN2 or CIN3 finding on colposcopy is like LEAP. LEAP is the best treatment modality for CIN2 and CIN3. What is LEAP? Loop electrosurgical excision procedure. Where there are limited resource countries, then VIA or HPV DNA testing is the screening tool which has been done. Now why pap smear, WHO say, should be like not as good as HPV DNA? Because the reason is any pap smear finding needs to be confirmed on colposcopy. So we should have a facility for a colposcopy. We need a trained gynecologist for doing a colposcopy, because like the health worker or the nurse, they cannot do the colposcopy. So that is why HPV DNA is a better screening modality than the pap smear. Now another question is, Rinke's crystals are seen in Sertoli cell tumor, Brenner's tumor or Leydig cell tumor. So these are the options provided to me. Anyone you want, you can write the answer. I can see your chat. So what answer you have marked, students? I can see Dr. Mohan Raj writing the answer for the previous question. Now what is the answer you have written for this? Rinke's crystals are seen in Sertoli cell, Brenner cell or the Leydig cell. So these are the inclusions in the cytoplasm. So the correct answer is Leydig cell tumor, which is a virilizing ovarian tumor, or it can be a Leydig cell tumor in the testis in males. Now next question is, 20-year-old female came to OPD. Her Ferriman Galway score is 6, showing hirsutism and BMI 29. All of the following are correct except. So different set of students have sent us different format of question. Some of the students have told me the question given to us was in the exam was, what are the correct options except the one. So the options are, you give OCPs, oral contraceptive pills, give OCPs and oral anti-androgens. Number 3, counsel regarding future metabolic syndrome. Number 4, weight management or lifestyle modification. Friends, always the best answer in case of a female presented with hirsutism, and I think in this question she is a case of diabetes also that was given somewhere. Case of diabetes also was given. The diabetes is because of the increase in insulin resistance occurring in PCOS patient, due to increase in the insulin resistance occurring in the PCOS patient. So if it is asked what is the first line or best management, first line management will be lifestyle modification or weight reduction. Okay, but if I take up this question, all of the following are correct except then OCPs, weight reduction, counsel regarding the future metabolic syndrome, these are the correct answers, and the wrong answer is OCP plus anti-androgen. Why I said this option should be ruled out? The reason is the OCPs which contains the third generation or fourth generation progesterone. Third generation progesterone includes the desogestrel or gestodine. Fourth generation progesterone includes drospirenone. So these OCPs which contains third or fourth generation progesterone, that is Yamini, with the name Yamini, and this desogestrel containing OCPs includes the Novilon or Familon. So what happens in this, these progesterone is known to increase the sex hormone binding globulin, and when the sex hormone binding globulin is been raised, which was down in PCOS patient, the free testosterone levels will decrease, and hence the hirsutism will get corrected, and further development of the hirsutism will not take place. Okay, so the first line management in a patient of PCOS who is presented with hirsutism and there is a Ferryman-Galway scoring is been given, the first step is lifestyle modification or it is weight reduction, and the second step is the drugs, and the best drug to treat hirsutism and menstrual disturbance is oral contraceptive pills, newer oral contraceptive pills which contains third or fourth generation progesterone, that is known to increase, I have just told you the mechanism of action, that is known to increase the sex hormone binding globulin, hence decreasing the free testosterone levels, so hirsutism will get corrected. So I am going to rule out the option number B, because when you are giving OCPs, you do not add anti-androgen along with that, because anti-androgen drug is a separate classification and separate drug, and OCPs, when one tablet is solving both the purpose, correcting the menstrual disturbance, correcting the hirsutism, and if it is a married female, providing the contraception. So I am just going to give one drug, not multiple drugs. So along with OCPs, we usually generally do not add anti-androgen drugs. But if another set of students has told me that the question was first line management or the best management, so I would like to mark weight reduction as my answer. So you are a better judge, students. Like you are a better judge, what was the format of question being asked? I have told you in both ways. If it was all correct except, then answer is B, OCPs and oral anti-androgen drugs. But if the question was asked what is the first line of management, which they have asked in AIMS 2020 PG entrance exam, then your answer is lifestyle modification or weight reduction or weight management. Next, this is what is a Ferryman-Galway classification, where on the upper lips there is growth of the hair, then on the chin, then chest, upper abdomen, lower abdomen. Okay, and according to this the classification is been given. Now, which of the following virilizing ovarian tumor, which of the following is a virilizing ovarian tumor? Again, different set of students have sent me different questions. One of the set of students have told me that this was the question in the exam, which one of the following is a virilizing ovarian tumor? Then answer is a renoblastoma, which is Sertoli Leydig cell tumor. Another set of students have given me question like this: which of the following is not a virilizing ovarian tumor? Then answer is Brenner's tumor is not virilizing ovarian tumor. Brenner's tumor is a surface epithelial ovarian tumor. Surface epithelial ovarian tumor, and like it is occurring in postmenopausal female, and it's quite a benign tumor. Okay, whereas Sertoli Leydig cell tumor, Hylas cell tumor are virilizing ovarian tumor. Virilizing, student, means the androgen secreting ovarian tumors. Virilizing means androgen secreting ovarian tumors. So either Sertoli Leydig cell was given, or they have written arenoblastoma. Both are the correct answers. But Brenner's tumor is not a virilizing ovarian tumors. It is a surface epithelial ovarian tumors. Now, what do you understand by the term virilization? Okay, first of all, the sex cord tumors of the ovary, sex cord stromal tumors. The correct term is sex cord stromal tumors. It can be the sex cord tumors, or it can be stromal tumors. The sex cord tumors can be feminizing, feminizing means estrogen secreting, that is granulosa cell tumor, or it can be virilizing. In the virilizing variety, it is Sertoli cell tumor, or it is Leydig cell tumor, or it is Hylas cell tumor. Stromal can be thecomas, fibromas. Okay, stromal can be thecomas or fibromas. What do you understand by the term virilization? Virilization means androgen secreting. So there is clitoromegaly, there is masculinizing body figure, then there is atrophy of the breast, then there can be secondary amenorrhea, and there is change in the voice changes occurring in the female. These are the features of virilization, and it is caused by androgen secreting ovarian tumors, that is virilizing ovarian tumor, Sertoli Leydig cell tumor or Hylas cell tumor. And the features of virilization is hirsutism plus defeminization. Now, next question is female patient with DMPA injection regularly. She is taking DMPA injections regularly, that is a 3-monthly or 6-monthly interval, but now she is 14 days overdue for the next DMPA injection. What will you do? The name of the DMPA injection available in the government sector is by the name of Antra. Okay, Antra, and the dose is 150 milligram 3-monthly interval or 300 milligram 6-monthly interval, and the failure rate is 0.3 per 100 women years. Now, what you will do? You will give DMPA injection. You will give DMPA injection with barrier contraceptive. That means you are adding up a backup method. You are doing urine pregnancy test before giving the next DMPA injection, or skip for the next cycle. What you will do? Now, before I tell you the answer, like according to WHO, the grace period for DMPA use is 2 weeks to 4 weeks on the study based, showing low pregnancy rate through 4 weeks. But the CDC expert did not consider this data as a generalized, because the study being done under the WHO was, like mostly the females who use the DMPA injection was breastfeeding females. Okay, so anyhow their cycles will be, they are getting the periods, or they may be having amenorrhea because of the lactation. So it suggests the grace period should be of 2 weeks. Now in the conclusion, the extended current WHO grace period for re-injection from 2 to 4 weeks does not increase the pregnancy rate and could increase the contraceptive continuation, because we don't want the female to stop contraceptive method. So if she is coming up now 14 days overdue, we would like to give the DMPA injection. We would like to give the DMPA injection to this female. Okay, so the correct answer is give DMPA injection, because we want her to continue the contraceptive, and according to WHO or CDC criteria, the grace period for DMPA is 2 weeks. Next, which of the following is the risk of progression of borderline ovarian tumors? Risk of progression of borderline ovarian tumors, is it PCOS, functional ovarian cyst, OCPs, or less parity? It is low parity was the term given in the exam question. So, like functional ovarian cyst occurs when the follicle fails to rupture. Okay, so this is not a risk factor. It is just a like observation which has been needed, and usually the cyst regresses. OCPs always gives protection against ovarian cyst and epithelial ovarian tumors. So it has got a protective role. Even PCOS directly do not increase the risk of ovarian tumors, but when we are giving continuous for say for a year or 2 years, we are giving ovulation induction, okay, and that might be a risk for epithelial ovarian tumors. But if I have to rule out, I would like to mark the answer as low parity, because we have been discussing in our classes that nulliparity or low parity is a risk factor for ovarian tumors. Number 2, that is genetic factors are also responsible, like BRCA1 and BRCA2 gene mutations which are genetically transmitted. Then Lynch 2 syndrome patients, that is HNPCC. Then there can be environmental factors like environmental exposure to asbestos or talc, or there is dietary factor, diet rich in fat. So the answer to this question is like low parity and nulliparity is a risk factor. And do remember that the borderline ovarian tumors remain, this is around seen in 5th decade, and they remain confined to ovaries for a longer period. They remain confined to ovaries for a longer period. There is no stromal invasion, and metastasis is absolutely very rare. These are the features of borderline ovarian tumors. Next question. A 13-year-old female was brought to the OPD by her mother. Upon examination, she was found to be 6 weeks pregnant. What is the most appropriate next step in management? Okay, so preserve the clothing. If she is already like 8 weeks pregnant, and I think in the question it was written UPT was done, which is positive. So preserving the clothing is of no sense to me. Okay, because had it been she has come up, if it has been like sexual assault been done, then there is a role of preserving the clothing. Okay, the next is register MLC and inform the police, take the consent from the mother and examining the genital organs, plan the MTP immediately. Okay, we do not plan the MTP immediately. Definitely we will be doing as a gynecologist the MTP, and like taking the consent from the mother is correct answer, but like first of all we have to inform the police and register the MLC. So I want you to discuss this question with the forensic medicine teacher, because that is the best one to, because it is an overlap question. As far as my knowledge, this question was being shifted to the gynae because of the two things: consent from the mother for examining the genital organs, and number two, the MTP should be done immediately. These are the 2 points which was written. So it is an overlap question between the forensic medicine and the gynae. So according to me, registered the MLC, inform the police and registered the MLC should be done as the first step. So like if any further question being asked in the subject of Obs and Gynae, you can write in the chat box, or you can send us like mail at the LN, and we would like to answer. If there is any question, you can type in the chat box and just let me know. I would like to discuss it here itself. If there is any change in the option also, that also you can let me know. So some of the questions which came, I have already discussed in my rapid recap session on the YouTube at LN Next. Okay, so some of the questions have become very repeat questions. Maybe the format of the question has been changed. There was 2 questions from the cancer cervix, that is, one is from the pap smear question, and another one was on the vaccine is being prepared, HPV vaccine is being prepared from L1 protein. 3 questions from ovarian tumor, in case crystals, then borderline ovarian tumors, and then virilizing ovarian tumors. Then 1 question from hirsutism and PCOS, 1 question another from the ovary, that is the peritoneal metastasis. So that is all I have collected from the students. I hope you have done the Obs and Gynae subject very well in your exams, because it's not very difficult questions according to me which was asked. It's not that I am faculty, just in general Obs Gynae usually comparatively students are able to solve the questions very correctly. So that's all the best. And prepare well for your upcoming NEET PG exam as well.
Welcome everyone to our FMT questions recall. Um, there are in total 11 questions that we are going to discuss. But before we begin to discuss this question, एक चीज़ जो मैं आज आपके सामने शेयर करना चाहता हूँ वो क्या है, जो हर क्लास में एवरी डिजिटल सेशन, एवरी ऑनलाइन सेशन, एवरी ऑफलाइन प्लेटफॉर्म आई कीप ऑन शेयरिंग विद ऑल ऑफ यू इज़ फोरेंसिक मेडिसिन आपका रैंक बनाने या फिर आपका रैंक ख़राब करने वाला सब्जेक्ट है. वाई? बिकॉज बहुत ही इजी या फिर बहुत ही मीडियोकर क्वेश्चंस जो हैं वो हमारे सब्जेक्ट में आते हैं. आई कीप ऑन सेइंग दिस अगेन एंड अगेन. इफ़ यू हैव रेड फोरेंसिक मेडिसिन वेल, योर चांसेस ऑफ स्कोरिंग 100% आर एक्सट्रीमली हाई, एक्सट्रीमली हाई, राइट. एंड ये जो INI-CET का एग्जामिनेशन था ये बिल्कुल भी एक्सेप्शन नहीं था. इनफैक्ट आई वुड रेट this year's November examination lesser as far as forensic medicine is concerned than the mid-year May examinations. Questions were very, very simple and very straightforward, right? तो चलो आगे चलते हैं. एंड इन बिटवीन हमारी क्वेश्चन के डिस्कशन में विल हैव द काइंड ऑफ फीडबैक्स जो भी आप लोग लाइव मॉनिटर पे दोगे. ओके. As with any other subject, I just want to create this, that these are recall questions. They have been recreated to the utmost simplicity for the understanding of the questions. आपके हो सकता है एग्जामिनेशन में किसी क्वेश्चन की प्रेजेंटेशन में कोई वेरिएशन आई हो, या फिर हो सकता है किसी चॉइसेस में एक आधी वेरिएबिलिटी हो. इफ़ देर इज़ एनी, वी कैन टेक दैट अप on the discussion portal also. Okay, wherever I have anticipated variability, I'll keep on telling from my side. So let's begin with our first question. Very straightforward question, a question from a very simple concept जो हम अपने examination में अपनी preparations में हमेशा पढ़ते हैं. The concept is about road traffic accident. The question say a person met with road traffic accident. All injuries can be found except. Okay, so here what you can see is that road traffic accident, RTA means road traffic accident. So we have road traffic accident. Okay, आंसर देखते हैं इसका क्या होगा, बट सबसे पहले देखते हैं कि व्हेन वी से रोड ट्रैफिक एक्सीडेंट्स, व्हाट आर द कॉमन थिंग्स जो ऑटोमेटिकली हमारे दिमाग में उसी समय आनी चाहिए. द फर्स्ट इज ब्लंट फोर्स impact, because in road traffic accidents we are expecting blunt surfaces. How? There could be a car who might have hit a pedestrian, there could be a vehicle who might have hit another vehicle driver, there could be people who are sitting inside the vehicle and the vehicle might have hit something and they may have suffered injury. Whatever is the way, the impacting surfaces are not sharp. So it's not an example of sharp weapon injury. So blunt forces are at play. Okay, which means we are expecting blunt injuries on the body, right? And what are the blunt force impact injuries that come up on the body? Whenever blunt force impacts the body, the injuries are abrasion, contusion and laceration. So we have abrasions, we have contusions, we have lacerations when we talk about road traffic accident and blunt force impacting the body. In continuation, when we say road traffic accident and a classical scenario of somebody being hit by a vehicle, what kind of injuries that we talk about? We talk about primary impact injury, we talk about primary impact injury, we talk about secondary impact injury, and we talk about tertiary impact injury, which are also called as secondary injuries. So, we talk about tertiary impact injury, right? And whenever we learn road traffic accident, we know one of the important tertiary impact injuries are grazed abrasion, when a person falls back onto the ground with the momentum he has been provided with the colliding vehicle and he slides onto the ground, grazed abrasions generate on the body. So, one very important typical injury that is seen in road traffic accident is grazed abrasion. So, whenever we talk about road traffic accident, grazed abrasion ऑटोमेटिकली शैल कम इनटू आवर माइंड. सो हमारे दिमाग में क्या चीज़ें आनी चाहिए? ब्लंट फोर्स इम्पैक्ट से होने वाली इंजरी जो कि है एब्रेजन, कंट्यूजन, लैसरेशन, एंड अ वेरी इंपॉर्टेंट ब्लंट फोर्स इम्पैक्ट से होने वाली ही इंजरी एब्रेजन का सब टाइप दैट इज ग्रेज्ड एब्रेजन. ये चार चीज़ें दिमाग में बिल्कुल कांस्टेंट होनी चाहिए रोड ट्रैफिक एक्सीडेंट के बारे में जब हम बात करते हैं. ओके, सो नाउ इफ वी सी आर options which are given with the question. Do we have grazed abrasions? Yes. Do we have lacerations? Yes. Do we have contusions? Yes. So RTA के केस में कौन सी इंजरी नहीं मिलने की उम्मीद है? The correct answer is chop wound. Chop wound नहीं मिलेंगे. Chop wounds are seen in injuries due to heavy cutting weapons like an axe. Okay, so chop wounds are result of heavy cutting weapons. Great. Right, Rahul has commented that all questions are from note. एग्जैक्टली राहुल, जो मैंने आपको नोट्स में, आपने नोट्स को देखा है, मैंने ये चीज़ जो है ये अपनी क्लासरूम में भी बार बार बोली है. बी इट नीट पीजी एग्जामिनेशन, बी इट INI-CET एग्जामिनेशन, फोरेंसिक मेडिसिन के क्वेश्चन काफ़ी स्टैंडर्ड के आते हैं, यानी कि उनका लेवल जो है वो बहुत ज़्यादा डिफ़िकल्ट नहीं होता. इसीलिए अगर हमने फोरेंसिक मेडिसिन एडिक्वेटली एवरेज मॉडरेट डिफिकल्टी लेवल की भी पढ़ ली है, द चांसेस ऑफ स्कोरिंग 100% आर एक्सट्रीमली हाई. राइट, आगे चलते हैं. चलिए, लेट्स सी नेक्स्ट क्वेश्चन. कैडावरिक स्पाज्म, अगेन समथिंग जो फोरेंसिक मेडिसिन में हम बहुत कॉमनली पढ़ते हैं, राइट, एंड कंडीशन विच इज सिम्युलेटिंग राइगर मोर्टिस. कैडावरिक स्पाज्म इज ऑल्सो नोन एज cataleptic rigidity, okay, cataleptic or instant rigor. राइगर मोर्टिस इंस्टेंट नहीं होता, कैडावरिक स्पाज्म इंस्टेंट राइगर कहलाता है. राइट, नाउ दिस इज वन थिंग which develops just before death, यानी कि इसका जो डेवलपमेंट है वो एंटीमोर्टम टाइम पीरियड में होता है, जस्ट बिफोर डेथ. ओके, सो यू कैन से द डेवलपमेंट इज इन एंटीमोर्टम time period, but it persists in postmortem time period. इसका मतलब क्या हुआ? See, when we talk about rigidity in the body, the common phenomena that we talk about is rigor mortis. Rigor mortis is something which is not present right at the time or the moment of death, it develops gradually in a dead body, which means the development of rigor mortis is 100% in post-mortem time period. Okay, so if there is a dead body, you will start to appreciate development of rigor mortis 2 hours, 3 hours, 4 hours after death, and it keeps on developing more and more, so it keeps on intensifying as the time period increases. Cadaveric spasm, on the other hand, which looks like rigor mortis, because in cadaveric spasm also there is rigidity in the body, but it is developing in the antemortem time period just before death, and the rigidity persists in postmortem time period, which means the moment you will see a dead body, even if it is a fresh death, if certain body muscles have developed cadaveric spasm, you will be able to see rigidity in those muscles instantly. Okay. The important features to remember about cadaveric spasm, apart from the fact that it develops in the antemortem or perimortem time period just before death, is it involves a particular voluntary muscle of the body. So, it is not going to involve all the muscles of the body as we see in developing rigor mortis. Cadaveric spasm involves only a particular muscle of the body, most often hands. Okay. So, these are kind of 2-3 very common information, very pertinent and important information जो हमें cadaveric spasm के साथ में बस याद रखनी है. So the moment somebody talks about cadaveric spasm, automatically हमारे finger पे होना चाहिए पेरीमॉर्टम टाइम पीरियड में डेवलप होता है, यानी कि मरने से कुछ समय पहले डेवलप होता है और मरने के बाद में वो रिजिडिटी वैसी ही दिखती है. सेकेंड, सारी मसल्स इन्वॉल्व नहीं करता, किसी एक पर्टिकुलर बॉडी मसल्स में ही इसका इन्वॉल्वमेंट जनरली देखा जाता है और सबसे कॉमनली वो इन्वॉल्वमेंट मिलता है हमें हैंड्स में. राइट नाउ व्हेन वी टॉक अबाउट राइगर मोर्टिस, द मैकेनिज्म ऑफ डेवलपमेंट इज डिप्लीशन ऑफ एटीपी, वो तो हम हमेशा ही पढ़ते हैं. कैडावरिक स्पाज्म का मैकेनिज्म ऑफ एक्शन is variable. It is seen in variety of conditions. Okay, lot of literature says depletion of ATP may be one of the reasons, but उन muscles में tremendous और बहुत fast ATP depletion हो जाता है just before death, and then there are many other situations or scenarios in which it may be seen. Is it seen in electrocution? Yes, I'll tell you why. Is it seen in drowning? Yes. Is it seen in suicidal firearm? Somebody committing suicide by shooting themselves in their head? Yes, in all these three conditions, cadaveric spasm is seen. Cadaveric spasm is seen. Is it seen in traumatic asphyxia? The answer is no. Not seen, because traumatic asphyxia किसी ऐसी डेथ कैटेगरी में नहीं आता जहां पर कैडावरिक स्पाज्म बॉडी में डेवलप होने की संभावना हो. सो क्या कुछ ऐसी पिक्यूलियर डेथ कैटेगरीज हैं? लेट्स सी देम. यस, if we talk about development of cadaveric spasm in certain peculiar situations of death, we see cadaveric spasm in deaths due to intense physical or emotional activity. Okay, what are the examples? Excitement, fear, severe pain, exhaustion, right? Cerebral hemorrhage, firearm wound to head, drowning, convulsant poison like strychnine. So these are certain situations. We talk about these in our study also. In fact, जब हम पोस्टमार्टम चेंजेस की बात करते हैं उस क्लास में मैं कॉमनली ये कहता भी हूँ कि आप सिर्फ एक ही चीज़ याद रखो, कैडावरिक स्पाज्म ड्राउनिंग के लिए बड़ा इंपॉर्टेंट है, तो ड्राउनिंग में तो डेफिनेटली कैडावरिक स्पाज्म को याद रख के चलना है. और दूसरा, एनी काइंड ऑफ फियरफुल और इमोशनल डेथ. सो ड्राउनिंग में तो एग्जॉशन में होती है, तो एग्जॉशन वी हैव ऑलरेडी कवर्ड हेयर एज एन एग्जाम्पल, राइट. तो फियरफुल, इमोशनल डेथ एंड ड्राउनिंग, अगर ये तीन चीज़ें भी हम याद रखेंगे ना, हमारा काम हो गया. सो इफ़ वी कम बैक टू द क्वेश्चन, यू विल सी ड्राउनिंग इज एन ऑप्शन जहाँ पर कैडेवरिक स्पाज्म होती है, वो दिया हुआ है ऑप्शन में. और फियरफुल एंड इमोशनल डेथ्स, इलेक्ट्रोक्यूशन एंड सुसाइड, राइट. तो हमारे पास बचा क्या, ट्रोमैटिक एस्फिक्सिया इज़ वन कंडीशन जहाँ पर कैडेवरिक स्पाज्म देखने को नहीं मिलेगा. ट्रोमैटिक एस्फिक्सिया की डेथ में जैसे किसी और डेथ में नॉर्मली राइगर मॉर्टिस डेवलप होता है, वो डेवलप होगा. ओके, सो अगेन दिस इज वन क्वेश्चन which could have been answered very easily if only somebody would have read the basic aspects of postmortem changes. उस basic aspect में ही हम cadaveric spasm की बड़े आराम से बात कर लेते हैं. Let's move further. Let's take our next question. Next question is an age-old question. Anybody who is preparing for any kind of PG entrance examination, ये एक traditionally और historically बहुत ही पुराना question है, और इस क्वेश्चन में ज़रूरत से ज़्यादा दिमाग लगाने की ज़रूरत भी नहीं है. इट वॉज अ स्ट्रेट फॉरवर्ड आंसर. पिन पॉइंट प्यूपिल्स आर कॉज्ड बाय. पिन पॉइंट प्यूपिल मीन्स हम एक ऐसी कंडीशन की बात कर रहे हैं जहाँ पर प्यूपिलरी कंस्ट्रिक्शन होने वाली है, और प्यूपिलरी कंस्ट्रिक्शन के लिए बहुत ही सिंपल एग्जाम्पल यहाँ दिया हुआ है, और द आंसर हियर इज ओपियम. द आंसर हियर इज morphine, opium and organophosphate. Okay, so opium, organophosphate, ये दो चीज़ें ऐसी हैं जो हमें याद रखनी ही रखनी है. बहुत सालों से कई बारी रिपीटेडली पूछी जाती है, राइट. मगर यहाँ पर दो चॉइसेस और दी हुई हैं, एक है कोकेन, एक एम्फेटामिन. अगर किसी ने आपने अपने एग्जामिनेशन से पहले रैपिड रिकॉल सीरीज़ देखी होगी जो हमने LNX पे करी थी, उसमें एग्जैक्टली सेम चीज़ मैंने अपनी स्लाइड में डाली हुई है, जहाँ पर आपको एम्फेटामिन, कोकेन, ओपियम एंड मैरिजुआना यानी कि कैनाबिस का एक टेबल बनाया था, जिसमें हमने सारी सिचुएशंस दिखाई थी कि वाइटल्स कैसे रहते हैं और आई की कंडीशंस क्या मिलती हैं. वहाँ पर क्लियरली देखने को मिल जाएगा. अगर नहीं देखी तो आप वो वीडियो दोबारा देख सकते हो, रैपिड रिकॉल का, INI-CET एग्जाम से पहले LNX का. सेम चीज़ उस टेबल में रखी हुई थी. इवन इफ समबडी वुड हैव सीन दैट वीडियो मे हैव बीन एबल टू आंसर दिस क्वेश्चन. नहीं भी देखा होगा तो क्वेश्चन वाज वेरी वेरी सिंपल. ओके, नेक्स्ट क्वेश्चन. हमें याद क्या रखना है व्हेन वी टॉक अबाउट पिन पॉइंट प्यूपिल्स. The simple mnemonic is PPPP, 4 दफ़े P, triple P plus P. Okay, so you can remember it as triple P plus P. Okay, triple P plus P क्या है? P for painkillers. यहाँ पर हम बात करते हैं ओपियोइड painkillers की, then phosphates, organo. We have organophosphates, pontine hemorrhage and pilocarpine, जो हम ग्लूकोमा के लिए यूज़ करते हैं ड्रग. These are 4 P's जिसमें हमें ये पिन पॉइंट प्यूपिल की कंडीशन मिलने वाली है. Let's move ahead. Okay, so one question was match the following kind of a question. The question was again not very difficult. In this question, basically you were asked to match the poisons with the kind of body systems जिस पे उनका manifestation होगा, उनका effect होगा. Okay, so again a very basic kind of a question. Okay, not a difficult one. So if you'll see, the first is nicotine. Nicotine is a cardiac poison. So we will say A matches with 1, right? सेकेंड इज स्ट्रिचनीन, जिसको हम कुचीला भी बोलते हैं, स्ट्रिचनस नक्स वोमिका भी बोलते हैं, राइट. दैट इज अ स्पाइनल पॉइजन. सो सी मैचेस विद 2. C matches with 2. Then third is Dhatura. Dhatura is a deliriant poison. It causes delirium. So it's a cerebral poison. So Dhatura will go with CNS. So we have B going with 3, and then nitric acid goes with skin. So D goes with 4. Nitric acid, if we throw nitric acid on someone, it produces yellow discoloration on skin. So remember, yellow discoloration on skin. So again बहुत ही बेसिक सी मैचिंग है, बहुत सिंपल. अगर हमने टॉक्सिकोलॉजी को सिर्फ ब्रशअप भी किया है एंड इवन इफ वी नो कौन सा पॉइजन किस कैटेगरी में आता है, वी कुड हैव ईजिली आंसर्ड द क्वेश्चन एब्सोल्युटली करेक्टली. सो करेक्ट आंसर इज A1, B3, C2 एंड D4. वो जहाँ पर भी ऑप्शन में दिया था, दैट वुड हैव बीन दी करेक्ट चॉइस इन दी एग्जामिनेशन. राइट, लेट्स मूव फर्दर. नाउ दिस इज वन क्वेश्चन जिसका आना थोड़ा सा मीडियोक्रिश है, इनफैक्ट बिलो मीडियोक्रिश है, बट हिस्टोरिकल इम्पोर्टेंस है एंड शायद किसी क्वेश्चन गिवर ने ये क्वेश्चन जो है हमारे एग्जामिनेशन में डाल दिया. But remember, whenever we are attempting to give any kind of an examination which is higher than the normal standard. So अगर हम ये कहें कि नीट पीजी जो है वो एक एवरेज नॉर्मल स्टैंडर्ड है इंडिया का, INI-CET एक हायर स्टैंडर्ड एग्जामिनेशन है, तो उस एग्जामिनेशन में कुछ क्वेश्चन हिस्टोरिकल इम्पोर्टेंस के, कुछ क्वेश्चन जनरल अवेयरनेस के होना थोड़ा सा लाजमी है. ओके, बट हाँ, आई वुड नॉट से कि वी शुड हैव गॉन बियॉन्ड सो मच कि हम 17th-18th सेंचुरी की वॉर्स के ऊपर बात कर लें. इनफैक्ट जिस एरा की मैं बात कर रहा हूँ, वॉर्स का मतलब क्या है, नॉट लिटरली द वॉर, बैटल वॉर जो फील्ड में होती थी. देयर वाज अ टाइम इन दी 17th-18th सेंचुरी जब ओपियम वॉर वर्ल्ड में छिड़ी हुई थी. ईस्ट इंडिया कंपनी उस समय ब्रिटेन की एक बड़ी ही स्ट्रॉन्ग ट्रेडिंग कंपनी थी. उनका ऑलरेडी इंडिया में स्ट्रॉन्ग होल्ड था एंड इंडिया यूज्ड टू बी अ वेरी डिसेंट प्रोड्यूसर ऑफ ओपियम. राजस्थान, यूपी एंड एडजॉइनिंग प्लेसेस में अच्छी मात्रा में खेती होती थी एंड दे वांटेड टू हैव दिस ओपियम कॉरिडोर फ्रॉम इंडिया टू हांगकांग, जो चाइना के गिरफ्त में था उस समय, एंड दे वांटेड टू सीमेंट देयर प्लेस इन दी हांगकांग एंड दैट इज़ हाउ दिस ओपियम वॉर स्टार्टेड बिटवीन देम एंड चाइना. एंड ये क्वेश्चन उस एरा को और ये क्वेश्चन उस टाइम पीरियड को रेफर करता है. सो करेक्ट आंसर इज़ वेरी सिंपल, इट्स अगेन ओपियम. ओके, सो इन 17th और 18th सेंचुरी जो भी क्वेश्चन में आया था, ब्रिटिश ईस्ट इंडिया कंपनी smuggled what from India to China? The answer is opium. Opium generates from poppy plant. Remember, ओपियम के बारे में हमने अपने रीडिंग में भी हम पॉपी प्लांट की बात करते हैं. पॉपी कैप्सूल होता है, पॉपी कैप्सूल को किस तरीके से इंसाइज करते हैं, दैट इज़ वर्टिकल इन्फिजन्स देते हैं टू कलेक्ट दैट लेटेक्स विच इज़ इनसाइड द कैप्सूल विच इज़ ओपियम. ये सारी चीज़ें जो हैं हम अपनी टीचिंग में बात करते हैं, बट अनफॉर्चुनेटली उस कॉमन चीज़ों में से क्वेश्चन आया तो समथिंग दैट हैज़ हैपेंड फ्यू 100 years बैक रिगार्डिंग concept called as the opium war that was initiated to win certain areas, geographical areas, for having that imperial supremacy. Okay, so we now know that the correct answer here is opium. अगले क्वेश्चन पे चलते हैं. which is not used in post-mortem identification. Now although it's little tricky, but it's not too difficult, right? If you read the question once or twice along with the options which are provided, we will start to understand what is the thing that the examiner wants to know, what is the intention of the question. Now the intention of the question is that post-mortem ho raha hai. So when we talk about post-mortem, we talk about a dead body, right? We talk about a dead body, and one of the aspects of conducting post-mortem is identification of dead body itself. See, when the person is dead and he has kids and kin or family relatives to identify the body, then identification of that dead is not that difficult. But particularly when we have unclaimed bodies, or particularly when we have bodies which are mutilated due to any disaster, then identification becomes a problem also. Okay, so just use your common medical sense. Common medical sense. If you want to identify someone, what are the common basic ways that you know of, right? One, you can use certain body fluids for identifying the blood group. The basic body fluid is blood itself. We can identify someone based on the antigenic properties of the blood. So when we say identification, blood groups can identify or help. So blood becomes a source of identifying a person. Second is DNA. DNA can identify a person, or at least can create a nuclear DNA profiling of a person, which can be used for identifying. It's one and the same thing. Okay. Now, do you think the answers which are given as options in the question, they may be helpful in identifying a person based upon his blood group, antigen or DNA property? The answer is simple, yes, we can use muscle for that kind of identification if needed. We can use blood, and we can use teeth also. Teeth can identify person in two ways. One is the wear and tear of the teeth, or maybe the morphology of the teeth can help identify a person, but then we need to have any ante-mortem identifying picture to compare with. And second, the pulp of the teeth, which contains the root, they help in identification of teeth via DNA sequencing also. So what is left here which cannot help in identifying a person is nail. Okay, keratinized tissues cannot be used for identifying either as any blood group finding or DNA extraction, right? So correct answer here is nail. Not a difficult one, again a very easy kind of a choice based on a very mediocre forensic science or forensic medicine knowledge, right? Great. Next one. In autopsy of a drowning case, water was not found in lungs and cause of death was given as dry drowning. What is the mechanism? Okay, so let's read what are the aspects of the question first. One is an autopsy is being conducted, so it's a dead body. It is given that it's a drowning case, okay, but an important finding is water not found in lungs, okay. The cause of death is also given as dry drowning. So although a negative statement is given that water is not present in lung, still it is a drowning case. The diagnosis of death has already been given to you that it is a case of dry drowning. Now all they are asking is what is the mechanism of death. Remember जब हम drowning की बात करते हैं अपनी क्लास में भी, then मैं आपको बताता हूँ कि ये दो तरीके की होती है. एक है टिपिकल, एक है एटिपिकल. टिपिकल ड्राउनिंग क्या होती है? इट इज़ दी वेट ड्राउनिंग, जहाँ पर एक इंसान जो जिंदा है वो पानी में गिरा, ही inhaled water as he was breathing, and because of his forced efforts of inhaling, the water goes into his respiratory system and he drowns and dies. उस बॉडी की ऑटोप्सी करोगे, आपको लंग्स में खूब सारा पानी मिलेगा बिकॉज ऑफ एक्टिव inhalations. Okay. On the other hand, there is something called as atypical drowning. Atypical drowning can be of three types. One is dry drowning, the second is secondary drowning, and the third is immersion. Third is immersion syndrome. Immersion syndrome. Dry drowning, person falls into water, the water starts to enter into respiratory tract. The moment the water enters into respiratory tract, laryngeal spasm develops, the person dies. So, the cause of death is laryngeal spasm. Secondary drowning, पर्सन पानी में गिरा बट और वो वाटर इनहेल भी कर रहा था, बट उसको किसी ने रेस्क्यू करके बचा लिया, उसको पानी से बाहर लाया, उसको थोड़ा सा रिसस्टेट किया, हॉस्पिटल में एडमिट करा दिया. ड्यूरिंग ट्रीटमेंट इन हॉस्पिटल्स ही डाइड ऑफ कॉम्प्लिकेशंस ऑफ ड्राउनिंग. रेस्पिरेटरी न्यूमोनाइटिस हो सकता है, पल्मोनरी एडीमा हो सकता है, सेरिब्रल एडीमा हो सकता है बिकॉज ऑफ वाटर एंटरिंग इनटू लार्ज क्वांटिटीज इन हिज सर्कुलेशन. तो यहाँ पर the death is happening not because of the acute effect of drowning, but it is happening because of complications of drowning. So, cause of death are complications of drowning, right? Immersion syndrome, person who is otherwise a very expert swimmer goes and jumps into water, the temperature of the water is really cold, the cold water splashes hitting his bare body, they increase the vagal tone. Sudden increase in vagal tone, increase parasympathetic discharge to heart, sudden cardiac shutdown, right? This is called as reflex cardiac inhibition, or you can say increase vagal tone. That is the reason for death in immersion syndrome. तो ये चीज़ हम अपनी क्लास में बड़ी इजीली फर्स्ट पेज पे ही पढ़ते हैं जब हम ड्राउनिंग की बात स्टार्ट करते हैं, द क्लासिफिकेशन इटसेल्फ, एंड द क्वेश्चन हैज कम फ्रॉम द क्लासिफिकेशन ऑफ ड्राउनिंग इटसेल्फ. आप नोट्स में जाके देखोगे, आप वीडियो खोलोगे, ड्राउनिंग का जो फर्स्ट सेक्शन है वहीं पर ये क्लासिफिकेशन अवेलेबल है. और हमारे एग्जामिनेशन में क्या पोर्शन आया इस क्लासिफिकेशन में कि ड्राई ड्राउनिंग का मैकेनिज्म क्या होता है. द आंसर इज सिंपल, इट इज laryngospasm or laryngeal spasm, right? Good. आगे चलते हैं. Now this is one question I would say जो थोड़ा सा decent question है coming from the area of forensics ballistics, but again a question which is very straightforward. Again हम क्लास नोट्स में और क्लास में ये बात बहुत सिंपली करते हैं. मैं पहले आपसे एक क्वेश्चन डिस्कस करता हूँ, देन आई टॉक अबाउट कि हमने क्लास में एक क्वेश्चन किस तरीके से टैकल किया है. द क्वेश्चन इज ब्लैकनिंग ऑफ एंट्री वुंड इन फायर आर्म इंजरी इज ड्यू टू ब्लैकनिंग ऑफ एंट्री वुंड इन फायर आर्म इंजरी. ओके, सो एक बार ही ना लेट्स ड्रॉ ए फायर आर्म. ओके, सो वी टॉक अबाउट दिस इन आवर क्लास ऑल्सो दैट वेन एवर अ फायर आर्म इज डिस्चार्ज्ड, there are four very important things that come out of the barrel. The first thing is the bullet itself, the bullet which is revolving on its axis, and when this bullet pierces the skin, it produces a hole in the skin. So let's say this is the skin barrier, the bullet is going to pierce, right? primarily indenting the skin and then piercing through the skin. So जब skin को pierce कर जाएगी तो क्या होगा, यहाँ पर हमें मिलेगा एक entry wound, right? So this is entry wound. But apart from bullet, there are three more things that come out of the barrel. One is fire. The second is smoke, because wherever there is going to be fire, there is bound to be smoke. And the third is partly burnt or unburnt gunpowder particles. So these three things are also ejected out of the barrel of the gun. Gunpowder particles, right? Now when these three things are going to hit a person, they are also bound to produce certain effect on the body. So let's assume that there is a person who is standing here, who is standing inside of this green line. Now you can see that fire reaches that green line, smoke reaches that green line, and the gunpowder particle also reaches that green line. The bullet obviously will reach farther than all these three products, which means if a person is standing inside the green line we have just drawn, he is bound to have effect of bullet, he is bound to have effect of fire, he is bound to have effect of smoke, he is bound to have effect of gunpowder particles. We have already talked about the effect that a bullet causes on the body, that is entry wound. What is the fire going to do? Wherever fire impacts, it will produce burning or singeing, या तो जलाएगी या फिर वो झुलसाएगी. Wherever smoke will reach, it will produce blackening. अब blackening का मतलब क्या हुआ? The smoke is merely getting deposited on the surface of the skin. Smoke is traveling, wherever it encounters the surface, it deposits on the surface, which means this blackening is going to be seen on the epidermal layer, and it is just a deposit on the epidermal layer, which means if you are going to wipe it off with a wet cloth, it will get wiped off also. Okay, it will get wiped off also, right? How about the gunpowder particles? The gunpowder particles, when they go and hit the skin, they are particulate matter. So they are definitely going to get embedded in the skin, piercing the epidermis. So they produce what is called as tattooing. These particulate matters, they are embedded into skin, which means they are not lying loose on the epidermis. So when you are going to wipe it off with a a piece of cloth, not a dry, even a wet cloth, that particulate matter which is embedded into the skin, that is not going to be wiped off. You cannot wipe it off. Yes, you can wipe off the blackening. Okay. So this is very, very simple and easy way that how we understand all these things in our class. So what is given in the question? Blackening of the entry wound in firearm injuries is due to, we know that blackening is due to smoke, which means unburned particle is not the right choice, flame is not the right choice, dust particle is not the right choice. What is the closest to smoke? Soot particles. soot particles are smoke particles. Okay, so either it was the choice was directly given as smoke, but lot of students said it was not smoke, it was soot particles. Soot particles are basically the black smoke that generates when there is burning of a flame. So correct answer here is soot particles, smoke, simple, right? Okay. Now let's see the next question. Again a very straightforward question. You can see whether it is a question of forensic medicine or you can treat it as a question of pharmacology. All are used in heavy metal poisoning except when we talk about heavy metal poisoning and we talk about treatment, we talk about chelation or chelating agents. So you just need to see out of the given choices which is not a chelating agent. So EDTA is a chelating agent, BAL is a chelating agent, penicillamine is a chelating agent. What is not a chelating agent? Oxime reactivators, they are not chelating agents. So that's the obvious choice. Oxime reactivators are used in organophosphorus poisoning to decrease the load of cholinesterase enzyme. They actively displace organophosphorus from the cholinesterase enzyme. So the bondage between the organophosphates and cholinesterases is broken. So cholinesterases are free to metabolize acetylcholine. That's how they help in organophosphorus poisoning. Okay, so that was a very simple one. Next question. Which of the following is not a grievous injury? Okay, again a question which is definitely from the domain of forensic medicine. There is no overlapping here. A very direct kind of question. They have directly asked you, what do you know about grievous injury? The thing to remember is grievous injury or grievous hurt is given in section 320 IPC. हम इसके बारे में क्लास में बात करते हैं that section 320 IPC has 8 clauses written in it. 8 clauses लिखे हैं. Any injury which can satisfy any one of the 8 written clauses can be qualified as grievous hurt. Right? अगर हम उस grievous hurt का आखिरी clause देखें, that is clause 8. Clause 8 is further subdivided into 3 sub-clauses, 8A, 8B and 8C. We can say like that. 8A is any injury which endangers life is grievous. 8B says which causes the sufferer for a period of 20 days to be in severe body pain is grievous. And 8C says which causes a sufferer for a period of 20 days not able to perform ordinary daily pursuits. अगर कोई ऐसी इंजरी होगी which will not allow a sufferer to perform ordinary daily pursuits for a period of 20 days is grievous. Okay? तो एक तो चीज़ हमें मालूम है, emasculation is grievous, ये grievous hurt होता है, clause number 1. दूसरा हमें मालूम है fracture of bone is a grievous hurt. Definitely हम जानते हैं fracture, any kind of fracture of bone or tooth is grievous. तीसरी हम ये चीज़ जानते हैं permanent hearing loss in one hair is grievous hurt. अगर permanent vision loss भी होता है in either eye, that's also grievous hurt. चौथा ऑप्शन जो है वो क्वेश्चनेबल है, उसमें लिखा है 7 days hospitalization. Now if a person is hospitalized for 7 days, he will not be able to perform his ordinary daily pursuits. Ordinary daily pursuits क्या होते हैं? उठना, बैठना, खाना, पीना, नहाना, ऑफिस जाना या फिर अपना नॉर्मल काम करना, whatever labor or job the person do. If he is hospitalized, he will not be able to do it with the ample ease that he is normally able to do, which means this is the only thing that can be given as the correct answer, right? But you can see that the choice is 7 days, and section 320 IPC says that if a person is not able to perform ordinary daily pursuits for a period of 20 days or more, then it becomes grievous. यहाँ पर 7 ही दिन है, so automatically this is not grievous hurt. So correct answer is 7 days in hospitalization does not qualify a hurt as grievous hurt. If it would have been 20 or more, we could have gone for this correct choice also. It could have been qualified as grievous. So यहाँ पर भी बहुत simple सा answer है, that is 7 days hospitalization is not grievous. Moving on to our last question, right? This is one question. मेरे से पहले जो आपकी गायनी मैम है उन्होंने भी आपको बताया that this question will be dealt by the forensic person because appropriately this question belongs to the category of forensic medicine. Let's see this question. A 13-year-old female was brought to OPD by her mother. Upon examination, she was found to be 8 weeks pregnant. So examination हो चुका है. She is 8 weeks pregnant. Some people say urine pregnancy test से confirm किया, so UPT was also given as a as in the question, right? What is the most appropriate next step? Okay. Now look at the age of the female, 13 years age. She is pregnant. Okay. Looks to be a case of sexual assault. Simple. हमें नहीं मालूम कौन कल्प्रिट है, बट डेफिनेटली इट्स अ केस ऑफ सेक्सुअल असॉल्ट ऑन अ माइनर, राइट. व्हेन वी रीड द डेफिनेशन ऑफ रेप, उसमें हम पढ़ते हैं कि इस तरीके के सेक्सुअल असॉल्ट्स में क्या क्या पनिशमेंट्स दी जाती हैं. बट राइट नाउ वी आर नॉट टॉकिंग अबाउट रेप, वी आर टॉकिंग अबाउट प्रोटेक्शन ऑफ चिल्ड्रन फ्रॉम सेक्सुअल ऑफेंसेस एक्ट, ऑल्सो कॉल्ड एज पॉक्सो एक्ट. सो थिंक अबाउट पॉक्सो एक्ट. पॉक्सो एक्ट क्या कहता है? वेन एवर देर इज अ माइनर चाइल्ड जो कि सेक्सुअल असॉल्ट का विक्टिम या विक्टिम हो सकती है, मेल भी हो सकता है, फीमेल भी हो सकती है, देर आर 2-3 वेरी बेसिक थिंग्स दैट यू नीड टू डू. एंड वन ऑफ द 2-3 वेरी बेसिक थिंग्स इज, वन इज टू मेंटेन द एनोनिमिटी ऑफ द चाइल्ड, कहीं बाहर किसी को नाम या कोई चीज़ नहीं बतानी है. द सेकेंड इज डू ए पुलिस इंफॉर्मेशन. मैंडेटरी है, आप इस बात को नहीं छुपा सकते. एंड अपार्ट फ्रॉम डूइंग अ पुलिस इंफॉर्मेशन, दैट इज क्लासिफाइंग इट एज अ मेडिको लीगल केस, यू कीप ऑन डूइंग वॉट एवर यू नीड टू फर्दर मैनेज द चाइल्ड. सो लुक एट द ऑप्शंस विच आर गिवन विद द क्वेश्चन. प्रिजर्व द क्लोथिंग, आप बाद में प्रिजर्व करोगे. क्वेश्चन पूछ रहा है व्हाट इज द most appropriate next step. So the moment you have identified that the child who is 13 is pregnant and you now understand that this is a crime, what are you going to do? You need to report the crime. So the simple one liner here is report the crime. How do you report the crime? Registered MLC and inform the police, right? Later on you will be preserving all the important evidences related to this case. उसमें आप क्लोथ का प्रिजर्वेशन भी करोगे, उसमें आप MTP भी प्लान करोगे for the medical treatment whatever is needed for that safety of that child, and take consent from mother for examining genital organs. अगर आपने ध्यान दिया हो तो अपॉन एग्जामिनेशन यानी कि बेसिक यूपीटी एग्जामिनेशन की कंसेंट तो ऑलरेडी हो चुकी होगी, राइट? क्योंकि यहाँ पर उसके जेनिटिलिया का एग्जामिनेशन होगा फॉर विच शी नीड्स टू बी अनड्रेस्ड, इट वुड बी एप्रोप्रिएट, ओके, टू टेक द कंसेंट ऑफ द गार्जियन अलॉन्ग. बट दैट इज अगेन a later step when you move into the examination of the child. The first appropriate step is report the crime. As a doctor, we should always know that whenever it comes to sexual crimes, okay, इसको thumb rule मान लीजिए, whenever it comes to sexual crime, the doctors are supposed to report the crime. राइट क्वेश्चंस जो हैं वो किसी भी हिसाब से उसके आसपास आ सकते हैं, बट अगर हमारा बेसिक फाउंडेशन है, हमें मालूम है दैट सेक्सुअल क्राइम्स आर सपोज टू बी रिपोर्टेड, देन आंसरिंग द क्वेश्चंस बिकम ईजी. Right, with that we end the discussion of these questions here. Okay, exam हो चुका है, so what we are leaving with is all the best for your examination results and your all the futures. Bye.
Hi everyone. How are you all? So today I'll be discussing the MCQs from the INI-CET November 2023 Biochemistry section. So let's start. So guys, these are the probable questions, right? And this is just, that's why we are calling it recall. And you are most welcome to add any option or any other question that you have right now. Okay. So let's start. See, looking at the paper in my subject, the questions were, most of the questions were, same or the repeats. There was little integration with other subjects also, and there were some new questions also. Like there was one new question that I'll be discussing at the question number 1. So though this question is not new for you, right, but I'll be discussing in my domain right now. Hybridoma technology uses which of the following? So guys, the hybridoma technology uses a purine salvage pathway. Now what is hybridoma technology? Let's understand this topic today in very clear format. See guys, hybridoma technology is used for what? So first of all, the answer is purine salvage pathway. It is used for the production of, so when you want to make the monoclonal antibody, right, which can be used for the treatment of various disorders. Now monoclonal antibody is very specific to a particular antigen. So when you insert the antigen, let's suppose that you took a antigen, inject into the mice. Now the mice, the B cells or the plasma cells, they will be producing the antibody which is specific to that particular antigen, right? Now what we get is a monoclonal antibody. Now if we take that plasma cell out and if we culture it, right, we can make this monoclonal antibody at the mass scale. But the problem is that plasma cell has a very short half-life. This is a problem. Okay, so the plasma cell, what is the problem? It has a short life, right? Short life. So if I take the myeloma cells, okay, if we take the myeloma cells, right, which are again plasma cells, okay, cancerous plasma cells, so they are immortal, right? They are immortal. Now if you fuse them using the polyethylene glycol or the PAG, then what we get is known as a hybridoma cell. So what properties I'll be getting by these two cells? Plasma cell, they have short half-life, but yes, they can make the monoclonal antibody. Myeloma cells, they can't make the antibodies, but their life is long, right? So we can achieve the mass scale production of the monoclonal antibodies if we combine them, the life plus antibody production. So guys, if we fuse them, right? So let's say if I fuse plasma cell plus the myeloma cells using polyethylene glycol, then I'll be getting hybridoma cells. Okay, hybridoma cells. But during the fusion, there is a probability that, okay, there will be a probability, just a second, I'll be taking a blank slide. Okay, so during the fusion, there will be a probability that the cells may be fused like this. Okay, so suppose I am selecting the two cells, plasma cells and M for the myeloma cells. Now when we fuse them using some technology, what are the chances of getting hybridoma cells? So we can get the cells which are plasma and plasma fused together, right? Then I'll be getting a cell where the myeloma and myeloma cells getting fused together. Then there are probability that plasma and myeloma cells fusing together. And this is what I want, this one, plasma and myeloma cells. Then there is probability that we will be having some unfused cells, right? Unfused cells like plasma cells and myeloma cells will also be unfused. Now I want to select only these cells. So to select these cells, I'll be using a medium that is called as HAT medium. Okay, so I'll be putting them in the HAT medium. Now guys, in the HAT medium, okay, in the HAT medium we have three things: hypoxanthine, H for hypoxanthine, A for aminopterin, and T for thymidine. So guys, the A is actually the aminopterin. Okay, and guys, this aminopterin is the inhibitor of dihydrofolate reductase. Okay, now, so what will be the outcome now in the HAT medium? So guys, during the in the medium, what I want is cell to proliferate. Okay, so cell proliferation should be there, right? I don't know what kind of cells are there right now. Cell proliferation need the nucleotide, that means DNA. Okay, so nucleotide synthesis, right? So guys, nucleotide synthesis can occur by two processes. What are the two processes of nucleotide synthesis? That suppose NS for nucleotide synthesis, they can occur by two processes. One is de novo, right? For example, when we read purine and pyrimidine synthesis, that is a de novo synthesis, right? And other is the salvage pathway. Okay, salvage pathway, right? When we read about that how we can reutilize the free bases, right? What is salvage pathway? Let's just revise quickly. Salvage pathway simply means that after the cell death, DNA is degraded. When the DNA is degraded, what we get is free bases, and the free bases I can use again, right? What I can do, I can use again in the production of the this thing that is called as the nucleotides again, right? So I will not make the uric acid out of the free bases. I'll use the free bases to make the nucleotides again. So I can use the salvage pathway also. Clear? And the de novo also. Fine. Now, guys, the point is that this de novo pathway is now already inhibited. Okay. So this de novo pathway is inhibited by aminopterin. So the cells will not be able to go through the de novo pathway. Fine. Now the salvage pathway. Salvage pathway is active in the plasma cells. Okay. Or hybridoma cells. P matlab plasma cells and H for hybridoma cells only. Fine. So it is not found in the myeloma cells. It is not there in the myeloma cells. So guys, which kind of cells will survive? The cell, this can survive, yes. This can survive, yes. Unfused plasma cells, yes, they can survive. But I told you already, plasma cells is a very short half-life, they will die. Fused plasma cells also have a very short half-life, they will die. So only the hybridoma, this is our H, hybridoma cells. H is not, right now I'm not talking about hat medium, H for hybridoma cells. This is our hybridoma cells. Okay, so they will only survive and we will be able to select them, like replicate them and get the monoclonal antibodies which are desirable, right? And guys, what is the name of the enzyme which is required in this pathway? The name of the enzyme that we need in this pathway is called as HGPRT, hypoxanthine guanine phosphoribosyl transferase. And this enzyme will use the H of the hat medium. What is H? Hypoxanthine. So guys, hypoxanthine will convert into inosine. Inosine makes the adenine and guanine both, right? It can make the A and G in the pathway, right? Okay, or it can use the free G, right, which is already present in the cells. And the T for thymidine, that can also be used by the enzyme thymidine kinase. So basically, this is the salvage pathway which is utilized in the process of the hybridoma technology. Clear? And what is the disorder of the defective purine salvage pathway? Lesch-Nyhan syndrome. So Lesch-Nyhan syndrome presents with hyperuricemia because the purine free bases are not reutilized but degraded by the process of purine degradation and makes the uric acid. So that is our question number 1, guys. So moving to our next question, number 2. Insulin independent absorption is seen in all of the except. So independent to insulin. So guys, RBCs are insulin independent, yes. Pancreas, yes. Brain, yes. In the RBCs we have GLUT1. In the pancreas we have GLUT2. And in the brain again we have GLUT1 or 3. Fine. So adipose tissue is the answer. So this is insulin dependent. The question is all except. So adipose tissue, they have GLUT4, right guys, GLUT4. GLUT4 is very important GLUT and it has been asked several times in exams, nothing new here. So this will be considered as a very repeat question. So guys, any cell like the 3 cells we have, the cells are skeletal muscles, okay, skeletal muscles. Then we have adipose tissue or the fat cells, and the third is heart cells or the cardiomyocytes. Okay. Now the heart cells, they rarely use glucose. I mean to say they are mostly dependent on the fatty acids 70 to 80% of time, but they can use it 25 to 30%, especially in the cases when there is, especially the cases like ischemia, for example, when they are experiencing the ischemia, right? Okay, in that case they can use more amount of the glucose, and also in cases of certain cases like the high blood pressure or high sympathetic activity, plus in cases of hypertrophy, right, and in cases of hyperthyroidism they can use more amount of glucose, hyperthyroidism especially, right? So these two cells are GLUT4 dependent or the insulin dependent. Now guys, we should know one thing, that the insulin, how does the insulin acts? The insulin binds to the insulin receptors, right? So these are called as the insulin receptors, right? And this is our insulin, pink color. And guys, the pathway name is called as PI3K AKT pathway, right? What is the name of the insulin signaling pathway? PI3K ACT pathway. And normally the GLUT4 is present in the vesicles, like as you can see here. Now these vesicles will fuse with the plasma membranes, as you can see here, and that is how the GLUT4 is expressed, right? So guys, GLUT4 expression is increased in by the insulin, yes. What else increases the GLUT4 expression? You should know that exercise also increases the GLUT4 expression, very important. And what else increases the GLUT4 expression? Catecholamines, okay, catecholamines, then thyroid hormones T3 or the T4, and guys, these are various factors which increases the GLUT4 expression on the cells, like maybe heart, muscles, or adipose tissue. Clear to all? Now the various GLUTs we should always remember, just a table here that we can remember. So guys, GLUT4 I have already discussed. GLUT1 is present in the placenta, muscles, adipose tissue, also a little bit brain and endothelium, and also the RBC. Clear? And GLUT2 is also very important because it is found in the beta cells of pancreas, liver. Guys, in the liver, the GLUT2 is bidirectional. Bidirectional means it takes the glucose, and store as glycogen. And once the glycogen is broken down, it releases the glucose. So GLUT2 is very important, and it is bidirectional in nature, that you should remember. Okay. And it is also found in small intestine. But where in the small intestine, guys, that is again very important to understand. This was recently also became important in one of the exams. See, if we look at the lumen of the intestine, suppose this is in the left hand side, we have the lumen of the intestine. So in the lumen of intestine, what we consumed is, let's say, glucose, galactose, fructose. So guys, glucose and galactose are absorbed through the GLUT1 to the enterocyte. So they enter into the enterocytes, and from there they will enter to the blood via GLUT2. So there was a question like this, that which of the following glucose transporter is present in the contraluminal, right? I will call this contraluminal, okay, GLUT. So contraluminal glucose transporter is present. What is the name of that? GLUT2, right? And fructose, GLUT5, right? That is present in the luminal side of the. So guys, this can be again a question, that all the sugars, whatever the sugar it is that we consume, it enters the blood from the intestine via GLUT2. Okay, ultimately it is the GLUT2 which is doing this process. Am I clear? Fine. So let's move to our next MCQ. Okay, so these are all the GLUTs that I just wanted to talk about. Fine. Light, there was a question, and this was a question which made everyone thinking it twice or thrice, because the question said light blue vial, okay, is used for the plasma glucose estimation. So what is the anticoagulant used in it? Okay, so guys, see, look at this question. First of all, the normal blood sugar, when we say I am doing blood sugar estimation, so what I do is actually fasting plasma glucose, or the plasma glucose estimation I am doing, right? So I need anticoagulant to be present in whatever the bottle or the vacuum cleaner I'm using. There should be anticoagulant because I want the plasma sample should be plasma, so anticoagulant must be there. So plasma glucose I have to do, right? Now the question says light blue vial, which we don't use normally. What we use is the gray vial. So that we all know, okay? We use what? The gray vial. Fine. Now gray vial has the potassium oxalate as the, so this option, right? Potassium oxalate is present in the gray vial. But the question is light blue vial. Okay. Now see, the examiner wants to do the plasma glucose in the blue vial. So I have to mark only the anticoagulant present in the blue vial, right? And that is citrate. So guys, citrate should be the answer of the choice, right? Though this question seems confusing, but even in the citrate, like when I mix the blood in the vacuum cleaner, so what I'll be getting is a plasma only, right? And citrate has not been found directly to interfere with the estimation of blood glucose or the plasma glucose. So basically, this question should go in the favor of light blue vial as answer. So what is the anticoagulant in the light blue vial? It is citrate. So I will not mark potassium oxalate, right? Because it's like, by mistake I did this, and sample of the patient is so precious, I can't, like, let's say the veins of the patient are not easily visible, a patient is maybe in the shock or something like that. So I need the sample to be preserved, and that is the sample I have. So I'll be using this. So this should be the answer, citrate. Correct? Okay. So it should not be something else. See guys, the various questions have been asked in the topic, that is vacuum cleaners. And I just want to tell you one more thing. Listen to me. Don't look at the image. Listen to me first. That most of the biochemistry test we do in the serum. The only test we do in the plasma, right, that in the biochemistry lab, that is glucose estimation. So that is gray vial, right, which has fluoride and potassium oxalate both. Okay, fluoride is an enolase inhibitor. That's why we are using it. We all know why we use the fluoride, because it inhibits the glycolysis. And if we don't use the fluoride, then the blood glucose decline every hour by 5 to 7%. So that can changes the value. If I estimate the blood sugar, let's say I collected the blood, but I am just testing it after 3 hours, right? Now my lab has so much rush. So that's the point. So we need the glycolysis inhibitor to be present, ideally. Fine. So guys, see in our question, this was the blue vial they said. Okay. Most of the time in biochemistry lab, I'll be using these two. That is clot activator of the plane, right, or the gel separator, that is golden yellow or the yellow. So I'll be doing all the tests of serology, immunology, LFT, KFT, urea, creatinine, whatever it is, right? So most of the time I'll be taking sample in these two. So I'll be using serum, right? Serum is separated. Blood will coagulate because it is a plain vial, correct? So if I ask you the question that what will be the vial that I'll use for estimation of TSH, serum TSH. So I'll be using these two, out of these two, anyone. They both are same except the gel is present in the golden one, correct? So this table can be helpful to you. And guys, this is also the order of draw. Okay, the sequence, as you can see, first I should take the sample in the this thing, that is a bottle, that is culture bottle, and the last should be the gray, that is having potassium oxalate, because it interferes with, if it is the first one, suppose it will interfere with all the hematological parameters, like because the fluoride and oxalate may interfere with the hematological parameters. That's why it should be taken in the last. Clear? Okay. So let's move to our next point. So guys, this is again just a citrate. What citrate can be used for? So these are all the tests that we can use citrate vial for. Next question. Which of the following is complementary with the active site of the enzyme? Okay. So guys, active site of the enzyme is a very specialized part of the enzyme, which has some amino acids, right, which are unique in the nature, and they are helping in the reaction mechanisms, right? They are not used there, but they can be used in the catalysis process also. So, but the point is that active side of the enzyme is not actually, complementary to substrate. No, it is complementary to transition state, right? I hope this option was there. If this option was not there, then answer can be substrate, otherwise answer will be transition state only. Okay, so guys, transition state see, normally we know this curve. Okay, so this is the reaction progression and this is the energy axis. So when we do the process, the curve is, let's say, like just a second, the curve is like, let's say, like this. Fine. So this is the substrate, the energy of the substrate, and this state is called as transition state, which is the highest energy state. And this is very, very, what I can say is, this is this state is not stable, unstable it is. So this can actually convert back to the substrate or can make the product, right? So that is unstable. So as per the laws of thermodynamics, anything which is having high energy, so this is very high energy, so anything which is having high energy is unstable, right? So transition state is very unstable. So this is a non-enzymatic reaction, no enzyme in this case. Now if I use enzyme, let's say, so if I use enzyme, then suppose this is my transition state achieved. Okay, so guys, this transition state has low energy. So what enzyme do is that enzyme lowers the energy of transition state. But how? See guys, the enzyme, suppose this is a enzyme, let's say that this is enzyme. Fine. So this enzyme can bind with the substrate. Okay, so this can be the substrate, like for example. Okay, or it can bind with the transition state. Suppose now I'm making the transition state. So let's say with a different color. So this is my transition state. Fine. So guys, this transition state is actually making various weak bonds with the active side of the enzyme. So these are non-covalent bonds. And guys, this energy is called as a binding energy, which will be released when these bonds are formed. See, substrate was like this only. It was not able to correctly bind or interact with the active site. But when the transition state is formed, it is able to interact completely with the active site. And it makes some non-covalent bonds. What are the non-covalent bonds? Like van der Waals and hydrogen bonds. So these bonds, when they are formed, they release energy, and this energy released is called as a binding energy. And guys, this binding energy lowers the energy of transition state. See, it was previously this much, now it is only this much. So the energy released will lower the energy of transition state, right? The peak of the hill is now low. So that is a stable transition state, and now it will convert into product. So there are high chances that this will convert into product. You got my point? Again, listen to me again. The transition state has high energy. Enzyme makes a transition state which has low energy. Now how this energy becomes low? See, anyhow the enzyme converts substrate to the product, but it's not direct. See, it's never like this substrate converts to product directly. There is always a transition state in between. So normally when the transition state is formed, it is unstable. Enzyme stabilize it. How does enzyme stabilize it? By binding energy. Enzyme and substrate, they make a bond. They make various bonds which are non-covalent in nature. Okay, and that releases energy, and that energy which release, that is called as the binding energy, right? So this will be called as binding energy. Okay guys, fine. So basically what happens if the active site is complementary to the transition state, then delta G, right, free energy is lowered, and the enzyme enhances the rate of reaction. So the rate of reaction will be enhanced, right? Why? Because the transition state has low energy. It will convert into product. That is enhanced. The products will be formed faster. That is the function of enzyme. Enzyme increase the rate of reaction. Clear? Okay. So this is again what I explained is written here. The enzyme stabilize and reduce, and this is some from one of the authentic book. So enzymes stabilize and reduce the energy of transition state structure by forming non-covalent bonds to it. So when the weak bonds like van der Waals and hydrogen bonds are formed, an energy is released called as binding energy, which lowers the energy of transition state and favors the product formation. Right? Okay. So guys, remember, active site is always complementary to transition state, not the substrate. Fine. So this is again a question that I teach normally and from the notes. So guys, that is the reason nowadays we have some drugs, okay, which are transition state analog. This is the term, transition state analogs. So what are the transition state analogs? They bind the enzyme tightly and inhibit the enzyme. Like for example, oseltamivir and the saquinavir in the HIV infection. Okay, neuraminidase is inhibited by oseltamivir and HIV protease inhibited by saquinavir in the treatment of AIDS. Even the penicillins are inhibiting the transpeptidase by the same mechanism. Okay, transition state analogs. Is it clear, guys? Next question. 2,3-bisphosphoglycerate binds with. So guys, 2,3-bisphosphoglycerate binds to the globin part of hemoglobin. Okay, it binds to the beta subunits, the space between the two beta subunits. Okay, that is the site of binding, this particular 2,3-BPG, which increase the release of oxygen. So guys, basically the point is, let's look at one figure first. Okay, look at this. So we know that is called as Rapaport-Lubering cycle. So we had already MCQs like how many number of ATPs are formed in Rapaport-Lubering, that is 0, net 0. Okay, so what is Rapaport-Lubering cycle? That when there is a no enzyme called as when there is need is required, like in the anemic condition or in the high altitude when we need more oxygen release. So this 1,3-BPG converts into 2,3-BPG, fine, and it will bind with the beta subunits of the hemoglobin, between the two beta subunits. Okay, now the point is, see, this is what it is shown here. Look at this in a simplified manner. It is the 2,3-BPG, which is binding with the cleft between beta 1 and beta 2 subunits. Clear? Now see guys, the beta the subunits, right, has 8 plus charges, right, as you can see here. So these are the amino acids: lysine, histidine, valine, lysine, histidine. Okay, so total charges, if you count, this would be like first charge, second, third, fourth, fifth, sixth, seventh, and eighth. So guys, total 8 positive charges are present in these two beta subunits. And 2,3-BPG has 5 charges, negative. Okay, let's see. This is 1, 2, 3, 4, and 5. So guys, there is, this is a phosphate compound. All the phosphate compounds have affinity for binding to this particular area in the hemoglobin, which is positively charged. Like ATP also has a high affinity of binding it, but normally ATP binds with magnesium, so it doesn't bind here. So this phosphate compound 2,3-DPG binds easily. It is negatively charged. So how many negatives? 5 negatives. Okay, there are total 5 negatives. Okay, what are the names of amino acid? Lysine, histidine, and valine. These 3 are involved here. Okay, so at this particular, and especially this amino acid beta position 143. So this is our hemoglobin A, right? So when the hemoglobin binds this 2,3-BPG, then oxygen affinity for the oxygen is reduced, and it will be delivered more to the tissues. That we all know. Nothing new in that. So this is what we should know, that what is the binding site of 2,3-BPG. That I'll always teach this in my class, and this is also in my notes, right? It's always there. Clear? So the only new question that I can say is hybridoma, that we generally don't discuss directly. Okay. See guys, it is again the same. Just one more thing I just want to tell you, that guys, the histidine of the fetal hemoglobin, right, is replaced by the serine, okay, at the position number 143. So that lowers the affinity of 2,3-BPG. That's why the fetal hemoglobin has a higher affinity for oxygen. So histidine at 143 position, you should remember this, is declined. Is it clear to all of you guys? Okay. Now let's move to the next point. See guys, 2,3 BPG levels are also rising in the anemic conditions, and one of the anemic condition is pyruvate kinase deficiency, right? Pyruvate kinase deficiency. So when there is a pyruvate kinase deficiency, that's the last enzyme of glycolysis. What happens? There is accumulation of all the intermediates, even the 1,3 BPG. So that's why 1,3 BPG converts into 2,3 BPG. So when there is a pyruvate kinase deficiency, there is a shift to right, okay? Shift to right happens in the pyruvate kinase deficiency anemia. Now hexokinase deficiency is also one of the cause of anemia, right? Simply because RBCs are affected, and RBCs has only one source of ATP, and that is glycolysis. So hexokinase, if it is deficient, then obviously ATPs are produced less, and that will be causing the anemia or the weakness of the membranes, right? Because membranes have sodium, potassium, ATP is always required there. So in hexokinase deficiency, the glycolysis will not start. So there will be no production of 1,3 BPG at all. I mean to say 2,3 BPG will not be produced. So that's why actually it will shift to the left, because the production of 2,3 BPG will be very low compared to normal. So hexokinase deficiency will cause shift to left, because the glycolysis has not even started properly, right? And in the pyruvate kinase, the intermediates are accumulating. So more to 1,3 BPG means more 2,3 BPG. Is it clear, guys? Okay, so that's it. That's all about this MCQ. Next question. Glycogen phosphorylase is activated by. So what is the answer to this question? Glycogen phosphorylase is normally activated by various pathways. See, taking the simplified version, first of all, I just want to tell you that glycogen phosphorylase is a rate limiting step of the glycogenolysis. Now, how it is regulated, there are various ways. Now, one of the way is called as the allosteric mechanism that I want to show you first. Okay, so this is the allosteric mechanism, first of all, that I want to show you. Fine. So, allosteric modulators of glycogen phosphorylase. First of all, allosteric activators. So guys, activators, there is none in the liver. There is no activator in the liver. Allosteric we are talking, right? You know what is allosteric means. And in the muscles it is AMP, adenosine monophosphate. Then we have allosteric inhibitors. Now allosteric inhibitors are ATP, one of the option in our MCQ, and glucose 6-phosphate, one of the option in our MCQ. Because guys, when the glycogen phosphorylase breaks the glycogen, it makes glucose 6-phosphate ultimately in muscles, for example, right? Because ultimately glucose never forms in the muscles, no? Because muscles lack glucose 6-phosphatase. So that's why the end product is always glucose 6-phosphate. So this will inhibit the further glycogenolysis if it is in the sufficient quantity, right? Okay, because glucose never forms in muscles, because the last step, glucose 6-phosphatase, is not there. And ATP. So guys, inhibitors are very simple. In the liver, the inhibitor is free glucose. So guys, remember, it's a key regulator in the liver. Fine. And fructose 1-phosphate also is the inhibitor of glycogenolysis. You must have read this in the fructose metabolism, right? That why there is hypoglycemia in fructose consumption in the patients with the hereditary fructose intolerance with the aldolase B deficiency, because fructose 1-phosphate accumulates and that causes inhibition of glycogenolysis. That's why the glucose is not formed from the liver, and that causes hypoglycemia postprandially. After the food, there is hypoglycemia. Is it clear? Fine. So that is the allosteric control of glycogen phosphorylase. Now, guys, allosteric control of glycogen synthase. So glycogen synthase is activated by glucose 6-phosphate. Okay, that is the most important allosteric activator. Fine, in both the liver and muscles. And glycogen synthase is inhibited by the glycogen concentration. So I told you the first of all allosteric mechanism, right? So in our MCQ we had two options, and they were ATP and glucose 6-phosphate. So that's obviously the these are the inhibitors, not the activators. So this will be not the answer. These two will not be the answer. Is it clear? Now let's move to the answer. Okay, First of all, let's look at the question again. Glycogen phosphorylase is activated by, guys, answer is calcium. Now see other option, not ATP I discussed, not glucose 6-phosphate, they are inhibitors actually. So the question is activated. And guys, protein kinase phosphatase, what was the option that you can tell me, but they will not be the direct answers. Okay, direct answer can be something like if they mention suppose cyclic AMP, that can be the answer. Or if they mention, let's say, AMP, that can be the answer. But you know, these two are not mentioned here. Okay. So if we talk about the other mechanisms like calcium, first of all. So in the muscles, calcium stimulates cyclic AMP independent glycogenolysis. So guys, what is the job of muscle? Muscle do the contraction, right? So calcium is responsible for both the initiation of muscle contraction and glycogenolysis. So whenever the muscle contracts, there is a release of calcium from sarcoplasmic reticulum, as we know, guys, which stimulates the delta subunit of phosphorylase kinase first. So there is one more kinase here, phosphorylase kinase. Okay, and that is actually a calmodulin because it binds calcium. It is a calmodulin. Okay, this you must remember, I believe. And it activates the phosphorylase kinase, right? And phosphorylase kinase converts the activates the glycogen phosphorylase by phosphorylation, and this causes glycogenolysis. And guys, the enzyme glycogen phosphorylase has two forms, A is active and B is inactive. That we all know. Okay, this is just to show you the structure, that this is the phosphorylase kinase, not the phosphorylase, it is phosphorylase kinase. It's not the direct stimulation by the calcium. So phosphorylase kinase binds the delta subunit, which is catalytic, binds the calcium and it becomes active. Is it clear? So this is how the calcium is important, especially in the muscles, right? Okay. Now, guys, just the hormonal part, if I have to cover. So we all know that in the hormonal part, there is one thing, first of all, you remember that muscles have no glucagon receptors, right? Muscles don't have the glucagon receptors. So whenever there is a fasting, we need the glycogenolysis or glycogen breakdown. Okay, so in the fasting, the glucagon levels rises, let's say in the liver. Glucagon activates the cyclic AMP production by the adenylate cyclase. Cyclic AMP activates the protein kinase A. Okay, and protein kinase A activates the phosphorylase kinase and that causes the activation of glycogen phosphorylase. Clear? So we have the total, two names of the kinases which are used here, that is protein kinase A and the phosphorylase kinase. Fine. Now, guys, in the muscles, though there is no glucagon receptors, there are the epinephrine, adrenergic receptors are there. Like if it is through the beta receptors, the same pathway is followed. Remember, through the beta receptors. And guys, if it is the alpha-1 receptors in the muscles, right, this will cause the activation of the enzyme. That is, first of all, we all know this, right? How does it happen? We can write it here like this. Okay, first of all, let's take it here. So alpha-1 receptor, they activate the G protein coupled receptors first of all. Then guys, G protein coupled receptors activate an enzyme that is called as phospholipase C. Phospholipase C converts PIP2 into two parts, that is IP3 and DAG. Guys, IP3 activates the calcium release, inositol triphosphate activates the calcium release. And guys, calcium when it is released, I told you it activates the phosphorylase kinase and activates the glycogen phosphorylase. And similarly, it activates the protein kinase C. Okay, protein kinase C. And guys, this protein kinase C inhibits the glycogen synthase by phosphorylation. It is now phosphorylated and it is inactive. As you can see, the red means inactive, green means active. Is it clear, guys? So it's a very simple figure and this will help you in the exams again, right? Everything is shown together here, and that I believe can be helpful for you. Guys, insulin always causes a degradation of cyclic AMP by the activation of which enzyme? This was also asked as a MCQ, phosphodiesterase. So remember that one also. So this question again, nothing new here. It is a simple MCQ, right? Which is there in your notes. and in your practice, right? So nothing new, but now be ready for little bit of more details, that little bit only, that I told you, like, calmodulin is the name of a subunit of phosphorylase kinase. Okay, let's move to our next MCQ. So which of the following is not helpful in the double strand DNA break repair? See guys, double stranded DNA break repair. Fine. This needs various proteins. Right. First of all, double stranded DNA break repair happens through the two pathways. The first pathway is called as, which is most common, non-homologous and joining. This is most common and prevents a cell death. And the second is homologous repair, and this is less common. Right? Why it is less common? Because to repair we have to separate the DNA, and guys, this happens during the S phase of the cell cycle, right? Okay, so in the S phase of cell cycle, the cell is rarely there in the S phase of cell cycle, right? Most of the time it is in the other phases. So in which there's the DNA is actually heterochromatin, or it is very tightly packed. So that is why these factors which are used in homologous repair, they are unable to access the homologous chromosome, right, for the repair of the deleted chromosome. Okay, we have the two copies of each chromosome, one from father, one from mother. So these are called as homologous chromosomes, and to repair one of the copy of the chromosome, I need the information from other chromosome. But if the other chromosome is already tightly packed, I can't access that, and that's why the homologous repair is very less commonly present. Why the non-homologous is present commonly? Because it doesn't need to repair the lost DNA or the deleted DNA. It is simply fusing the two ends of the DNA. Clear? So that is not our question. What is our question is that, and guys, one more thing, why the S phase of cycle is the most radio resistant? This was the recent MCQ, as you know, because the S phase of cell cycle is very much radio resistant, because homologous repair is very much active. As soon as there is a damage, it will repair it correctly. It is error free, right? Homologous repair is error free, and this is very much error prone and can cause various mutations, right? Okay, now the question is the names of proteins. So you guys, there are a lot of proteins which are involved in this, right? And I always talk about these proteins, especially those which are given in the MCQ. And then definitely there are a lot of others, but I always talk in my lectures these proteins which are already given. First of all, guys, what we can do is, answer is A. Why it is A? Not, they're asking not. A is utilized in one of the process, and what is that process? That is called as the mismatch repair. So guys, I have mentioned here. So in the mismatch repair, right, like what is a mismatch? When the A bind with the C or A bind with the G, like that is mismatch. So the names of the proteins are like named as MSH and MLH and PMS. Okay, so now you remember all of them. MSH, MLH and PMS. Okay, that is, these are the names. You might have read them also in your surgery with the CA colon probably, right? What is the defect in mismatch repair? HNPCC, right? We all know. Okay. Now guys, base excision repair, and this is the base excision repair, and in the base excision repair we need the gene MUTYH or MYH. So the glycosylases are coded by the MYH gene, or the name of the protein is MYH. So this is again we talk always in the lectures, and even I talked about this in my revision session for the rapid recap of INI-CET, right? Then guys, we have the nucleotide excision repair, the third repair mechanism, and the proteins in them are named as XP, that is xeroderma pigmentosum proteins, and they can be like A, B, C, D, E, F, G till H. Okay, so remember they are written like this, XP proteins. Okay, then guys, for homologous repair and non-homologous repair, okay, so for homologous repair we need BRCA1 and BRCA2, ATM, then the Werner, and then the Bloom, which are helicases, and the RAD51. Okay, so like ATM is the one which identifies the lesion, BRCA1, BRCA2 and RAD51, they are able to take the information from the homologous chromosome, which is undamaged part of the chromosome. I told you 2 chromosomes we have. So one is undamaged right now, suppose other is damaged. So these 3, BRCA1, RAD51, they help in the taking information and ultimate repair. And WRN and BLM are the name of helicases which help in separating the DNA. So Werner syndrome, Bloom syndrome. And guys, BRCA mutation causes ovarian and breast cancers. That is, again, we should remember MCQ. Fine. So these are the points that we should remember in the homologous repair. Now, as in the non-homologous repair, right, let me show you. In the non-homologous repair, when there is a double strand break, I need a protein that is called as KU7080. So these are very important proteins. Why? Because they bind at the ends of chromosome and prevents the further damage, right? They prevent the further damage or breakdown. And then comes the other proteins like DNA protein kinases. That is in our option. Artemis, right? Artemis and DNA protein kinases. They are again very important proteins. And then we need some polymerase definitely, and the ligase. See, the sequence is always like this. First enzyme is the one which is called as endonuclease, which removes the undesirable part. Then we have polymerase, and then we have ligase. It's always the sequence. Endonuclease, polymerase. See, it will be like this: endonuclease, polymerase, and ligase. It's like this. Okay. So Ku proteins are involved here, and guys, the defects in the Ku protein causes what? They make the cell sensitive to the X-rays or the ionizing radiation. Fine. And guys, non-homologous end joining is also important for the VDJ rearrangement. So if that is also a problem, this will cause SCID. That is again a MCQ, very important. SCID and sensitivity to the ionizing radiation or the X-rays that you can remember. Is it clear, guys? So now is the time, right, that, okay, those are one of my few old students who are listening to me, that these are the proteins we always talked about. And if you gave this exam, these are the important proteins, right? I used to mention, write them in the notebook. Okay. Next question, guys. So only few students told me that there was a question something like that, but not exactly like this. So please let me know if there is anything that can be changed here. Okay. So why there is a hepatomegaly in the glucose 6-phosphatase deficiency? Okay. So hepatomegaly in the GSD with glucose 6-phosphatase deficiency, right? That will be deficiency. So what is the answer? Guys, see, it is a von Gerke's disease. So in the von Gerke's disease, that is GSD type 1, what happens is that there is a deficiency of glucose 6-phosphatase enzyme. So when there is a deficiency of glucose 6-phosphatase, there is increase in glucose 6-phosphate. So there are 3 clinical features which appear because of these 2 points. First, because glucose 6-phosphatase decrease in glycogenolysis and decrease in gluconeogenesis. Both the pathways have this enzyme as the last enzyme. So guys, this will cause the severe hypoglycemia. So I'm explaining everything that can be asked in future also. That is already in our notes and in your notes probably, right? Okay. So severe hypoglycemia. So now next time they can ask you that why there is severe hypoglycemia in von Gerke's disease. So this is the answer, because there is deficient the last step of both the pathways which maintains the blood sugar level, that is gluconeogenesis and glycogenolysis, correct? Then if there is increase in glucose 6-phosphate, guys, there are 2 possibilities, right? What are the 2 possibilities? First of all, glucose 6-phosphate, I told you already, activates the glycogen synthesis. So guys, because of this, there will be, this is allosteric activator I told you just now, massive hepatomegaly, or maybe also renomegaly, right? Plus I'm writing renomegaly, that can be also present, right? So these 2 are the important things that can happen in this case. Now glucose 6-phosphate, if it is increased, guys, this will also enter the HMP shunt. What is the product of HMP shunt? Pentose phosphate, that is like ribose 5-phosphate, I can write ribose 5-phosphate. So guys, there will be more amount of nucleotide formed like purines and pyrimidines both, but from the purines I'll be getting uric acid. So guys, this will lead to hyperuricemia. Okay, if you are unable to see because I am in the I'm blocking the view. But what I'm saying is that more amount of nucleotides are formed, so more amount of uric acid is formed, and that will cause hyperuricemia. Is it clear to all? So guys, these are the three important points that you should remember in the von Gerke's disease. And one more is that there is always a negative glucagon challenge test. Don't forget this line. Okay, this can be a future MCQ. Glucagon challenge test. Why? Because last enzyme is missing. Even if you give glucagon, it will activate the glycogenolysis, but glucose will not form, so there will be severe hypoglycemia always. So glucagon is not able to increase the blood sugar. Why? Because the last enzyme is missing, so it can't be formed. Okay, guys, there was a question which was given as a image was given, right? And in the image they have just clearly mentioned that some toxin or something compound is inhibiting the elongation factor 2, which inhibits the protein synthesis. So guys, elongation factor 2 is required for the purpose. What is the role? That is called as ribosomal translocation. Okay, ribosomal translocation. So that is elongation factor number 2, right? Ribosomal translocation. Now this is inhibited by a toxin, and that is called as, what is the name of toxin? Diphtheria toxin. So exactly what was the question? That they gave the image and they asked the name of the toxin. So guys, that is diphtheria toxin is the answer. Or if they gave the name of the toxin and they asked what is the site of action, then elongation factor number 2 is the answer. See guys, remember one thing, that diphtheria toxin, okay, what it does do, it takes the it act as act as a protein which transfer the ADP ribose, right, obviously from NAD. So transfer the ADP ribose to the diphtamide amino acid. Guys, what is diphtamide amino acid? This is modified histidine. Okay, it's a modified histidine. You must remember this, that this is modified histidine. What is the name? Diphtamide. No other protein in the human beings till now has been identified to have diphtamide. So this histidine is, ADP ribosylation of this protein is happening, and this inhibits the protein, right? So inhibit the elongation factor number 2. Okay, so to the diphtamide of elongation factor number 2. Clear? Which inhibits the translocation process. What is the job? Translocation process. Right guys? So this is diphtheria toxin. Many times it has been asked previously also. So now you should know these points also. And guys, one more toxin that is present in the eukaryotic translation inhibition is ricin. And what is the job of ricin? Ricin inhibits the 28S ribosomal RNA. Right? Basically it will remove the adenine from this 28S ribosomal RNA, which act as peptidyl transferase. What is the job of this enzyme? To make the peptide bond. Right? This is a ribozyme. Ribozyme example, 28S ribosomal RNA, which is part of 60S subunit of the ribosomes, and it is inhibited by the castor toxin from the castor, that is ricin. Okay, so that's all about this point. Fine. Now let's move to the next point, next question. So guys, again this question is linked with the other subject like micro. Nucleic acid of which organism has A not equals to T? So guys, obviously we can look for two things. First of all, this question is based on Chargaff's rule. Okay, Chargaff, not exactly the Chargaff's rule, but the Watson and Crick base pairing, right? The base pairing is like A, T and GC. And in the Chargaff rule, we all know that in the double-stranded DNA, A bind with the D and G bind with the C. So A should always be equals to the T, or the A plus G is equals to C plus A plus G, that is purines, are equals to C plus T, that is equals to pyrimidines. Okay, so purines are equals to pyrimidines, that is A plus G is equals to C plus T. So in the MCQ, they're asking which organism. So guys, any organism which is either single-stranded DNA RNA or either it is a RNA virus. You getting the point? If it is a single-stranded DNA, then even not A is not equals to T, right? And if it is a RNA virus, then A is equals to U, not the T. So there is no T. So based on the recall option, HIV can be the best answer because that's a RNA virus. Or if it's a COVID virus or whatever, depending on the options. Guys, human mitochondrial DNA is a double-stranded, right? So it is double-stranded, this is double-stranded, this is again a DNA virus, which is herpes virus, right? Okay, so HIV sounds to be the best answer here. That is the RNA virus. Clear to all? So that's a simple one. Now, next question was based on alternative splicing. So the question was probably like this, that the B cell co-express the two B cell receptor isotypes, IgM and IgD. Okay, so this is due to which of the following phenomenon? So guys, answer is alternative splicing. Okay, so from the one gene, that is, when they write isotype, or even if they don't write, we know that IgM and IgD are isotypes, right? So they are made from the one particular heavy chain gene. Okay, and they have similar identical antigen binding domains but distinct constant regions, right? Constant regions are different, so they can be made by a process that is called as alternative splicing, right guys? This question can also be asked like this, that how come we have the same antibody, like suppose IgM can be acting as a B cell receptor, it can be secreted also. So the same antibody can be secreted also, and it's a part of receptor. It's a receptor also. Why? How? Alternative splicing. So what happens in the alternative splicing, guys? We remove a particular exon. Okay, suppose this is a single-stranded mRNA only, which is unmodified, and it is having exon number 1, exon number 2, then it has an intron, and then suppose it has exon number 3. Okay. Now, what is the meaning of all splicing is that if I remove the exons, I mean to say introns, and join the exons. So E1, E2 and E3. So this was our unmodified mRNA, and this is what I get as a mRNA number 1. And guys, from this I'll be getting a protein which is number 1. Okay, like suppose this is Ig, any particular isotype of Ig. And guys, if I do the process that is called as alternative splicing, so what we can do, one of the processes called as exon skipping. So I'll skip one exon. If I skip one exon, then I can get only two exons here. Suppose E1 and E3. I don't take E2 suppose. Similarly, I can also do one more thing, that is I can take two exons, that is one is E2 and other is E3. So guys, this way we can get two proteins, that is protein number 2, and this will give me protein number 3. If it is not visible, I just mentioned protein number 3. It was E2 and E3 I took only. So that will be the protein number, okay, 3. Fine, this side. Right guys, so this is why we have only 30,000 genes and we have more than 1 lakh proteins. So why this is there? Because of alternative splicing. Okay, we are changing some properties of the enzymes or the proteins by removing one exon. Suppose the one of the protein is fixed, suppose this is a protein, it is fixed to the cell membrane. So that is one protein, and the same protein is suppose secreted outside, because the exon which codes for this region, hydrophobic region which inserts into the membrane, that is removed. I have removed the exon, suppose E2, which codes for the binding domain to the cell membrane. So this protein will become secreted now. So this is a secreted protein and this is a cell bound protein. So guys, that is the importance of alternative splicing. So what we get? We get terms, that is isoforms, right? Protein isoforms we get, or you can use the term isotypes of the, let's say in this case, that is antigens. Am I clear, guys? So the best answer to this question is alternative splicing. So guys, thank you so much, and all the best for your results. Bye bye.
Hello everyone. So now we'll discuss the radiology questions. So not a lot of questions from radiology, and in general INI-CET does not ask radiology specific questions that much. Most of them are integrated into clinical subjects like medicine, Obs Gynae, orthopedics, surgery, etc. But I've taken out the radiological questions separately, and we'll discuss what were the questions that were asked and what are the answers to them. And we'll keep it short and crisp because I don't want to explain each and every subtopic in detail because we have separate lectures for that, and the recall series, in my opinion, should be just limited to the discussion of the questions. So the first question here was a child playing alone and is found to be drooling and choking. So I think this was sort of the question, not the exact language of the question per se, but this was a question related to ingested foreign body. Now we know that whenever in an AP view X-ray, if in an AP view X-ray we see a circular body, then it has to be in the esophagus. Okay, it cannot be in the trachea because trachea has vocal cords, and for any foreign body to pass through the trachea, it has to be longitudinal like this. So if on an AP X-ray view you see a circular body, it has to be in the esophagus. Now the question was not whether it was in trachea or it was in the esophagus, but what was the foreign body per se. Now this is a very frequently asked question in INI-CET. It's a previous question, but most of the time they ask it regarding coin. Now this time they specifically gave two views of the X-ray. One was an AP view and another was a lateral view, and you can see that it has a beveled edges. It has beveled edges and it is a circular. So it is not a coin, and since they've already asked a coin previously, now the probability of asking some another foreign body increases. And so which is another round foreign metallic body which a child ingests? So that is a button battery. What is the clue to this button battery? It has these beveled edges. Okay, it has these beveled edges. That is the clue to it being a button battery and not a coin. Now let's see the next question, a simple, very simple question related to ligaments of the knee. So an MRI image was given, and this was the image which a lot of students have told me, sir, this was the image that was given. There was a ligament, a cruciate ligament that was asked on a sagittal view of an MRI, and it was attaching to the posterior part of the tibia. So straightforward answer, this is the posterior cruciate ligament. Sorry, it has not been mentioned in the options here. It is the posterior cruciate ligament. This is the posterior cruciate ligament because it is attaching to the posterior part of the tibia right here. Now, this was discussed in a rapid recall session that we took just before the INI-CET, and you can see in this image. In fact, this was shared to me by one of the students only. Sir, this directly came from your rapid recap series, and we took that series just before INI-CET, a month from 5th October to 25th October. And in radiology, I showed you top 50 images, and this is exactly the image showing PCL that we discussed in the rapid recap series. Now, in this image, I want to show you another ligament, which is the anterior cruciate ligament. Now, anterior and posterior cruciate ligament, how do you differentiate on an MRI? You see the insertion on the tibia. So, if it's inserting anteriorly, it is ACL. If it's inserting posteriorly, it is PCL. Now, where will be the patellar tendon? So, this will be the patellar tendon. This will be the patellar tendon. And this is the quadriceps tendon. This is the quadriceps tendon. So, a simple question from the cruciate ligament anatomy, which was asked in this INI-CET. Now, the next question is regarding the choice of investigation when we are evaluating a parathyroid adenoma. So, I think this was not the direct language of the question per se. The question mentioned a suspected case of hyperparathyroidism, primary hyperparathyroidism, and a parathyroid adenoma is suspected. So, for a pre-op localization, so if we are to do a pre-operative localization of parathyroid adenoma, what will be an investigation of choice? Now, parathyroid adenoma, we know, can be present at the normal location of the parathyroid gland. So, they can either be orthotopic or they can be ectopic. So, meaning they can either be in the normal position, that is behind the thyroid gland, or they can be ectopic. Now, ectopic parathyroid glands, can range from anywhere, can happen anywhere from skull base to the mediastinum. Okay? And if we want to see an ectopic parathyroid adenoma, then we'll have to do a 3D investigation. A 3D investigation will be much better than a 2D investigation. And we know for parathyroid adenoma, we do technetium 99M, SESTA may be, because this SESTA may be if taken up by the parathyroid gland. Now, what to do? Should we do a scan or should we do a SPECT? Now, scan is nothing but a gamma camera. That is, it is a 2D image. Whereas SPECT is computed tomography, single positron emission, single photon emission, computed tomography. So, it is 3D. So, the answer here will be SESTA, maybe SPECT. We always want to do a 3D investigation to localize a parathyroid adenoma and never a 2D investigation. Now, why is ultrasound not an investigation here? Why is ultrasound not the answer here? Because it will not be able to localize any ectopic parathyroid gland. And likely, with respect to SESTA maybe and CT scan, SESTA maybe is much more sensitive because SESTA maybe is taken up by the parathyroid glands separately, and so it will appear bright on a SESTA maybe SPECT. So, I hope this answer is clear, that the answer here is a SESTA maybe SPECT for parathyroid adenoma. Okay. Now, let's discuss the last radiology question that I could gather from the students. Now this is a controversial question because a lot of students told me some different version of this question, and I could not really gather the exact image of the question from anybody. So we'll discuss what could be the possible options, what could be the possible answer if different images are given to us. But most of them did confirm that yes, it was an orbital image, a CT was given, and there was some inflammation in the orbit. Now whether it was pre-septal, post-septal, that we don't know. So it was mainly a URTI patient with orbital pain, and one of the CT was given, CT image was given. Now if the CT image was like this, now what do we see here? This is the left side, this is the right side. This is a contrast enhanced CT of orbit. Why do I say contrast enhanced? Because I can see contrast in the internal carotid artery, in the vessel, so it's a contrast enhanced CT. And in the orbit, I can see some thickening and fat stranding anterior to the eyeball, this region. So this is the pre-septal, this is the pre-septal space anterior to the eyelid septa, it's the pre-septal space, and if this was the image, then the answer would be a pre-septal cellulitis or a pre-septal abscess. If the inflammation was here, then the answer would be a pre-septal cellulitis. But I am not sure if this was the image that was given to us. So you can tell me in the comments whether this was the image that was given to us or not. However, let me just take this opportunity to tell you various orbital infections. So there is a Chandler classification of orbital infections in which we see what space of the orbit is involved. Now most of the orbital infections occur secondarily to URTI, secondarily to a sinusitis, because the infection spreads from the sinuses into the orbit. Now if they affect the pre-septal space only, then that is the pre-septal cellulitis, like this. So this is also a pre-septal inflammation, and you can see some abscesses formed here. You can see peripheral enhancement. So this in case is a pre-septal abscess. Now sometimes secondary to sinusitis, what you get is this subperiosteal abscess. Now this is a subperiosteal abscess. Why? Because it is lifting up the periosteum and it is concave in shape. It is concave in shape, convex in shape. So if any convex shaped abscess adjacent to the bone is there, then this will be a subperiosteal abscess. But if the inflammation is both anterior, posterior to the eyeball, it is involving the orbital fat like this, the arrow showing, then this is orbital cellulitis. And you can very well see that because there is so much inflammation behind the eyeball, that is in the retroorbital space, there is proptosis. There is proptosis. Here there is proptosis, marked proptosis as compared to the left hand side. So you tell me which was the image that was given in the question, because the answer was an image based question, and whatever the image, the answer will change to that. So in a pre-septal cellulitis, the orbital fat will be very clear. It will be very clear like you see in this image. But only the pre-septal space, that is space anterior to the eyeball, will be inflamed or thickened. So you see on the right hand side, this is so thin, the skin anterior to the eyeball, that is the palpebral, that is the eyelids are so thin, but here they are inflamed. So this is left side pre-septal cellulitis. Now how will a subperiosteal abscess look? Let me just recapitulate again. It will be a convex shaped abscess adjacent to the bone, because it is lifting up the periosteum, so it will be convex shape like EDH we remember in head trauma. In comparison, an orbital cellulitis will affect the retroorbital space completely, and it will cause proptosis like this. It will cause proptosis like this. So depending upon which image was asked in the question, the answer would change. And so I've overall given you a brief overview of what could be the answer depending upon the image that was shown in the question. So that's all from radiology point of view. Thank you.
Hello everyone, welcome to this INI-CET anesthesia questions discussion. I got 6 questions and most of the questions are very predictable questions. 3 questions directly from the oxygen delivering device. The topic I always say it's a very high yield topic with a lot of questions expected from that topic. 1 from pre-anesthetic evaluation and 1 question from drug and 1 question from a clinical question with integration with other subject which I will discuss. So these 6 questions, let us start discussing. The first question from the topic oxygen delivering device. First question from oxygen delivering device. So I discussed this topic very nicely in your lecture in the app, and I told you in this topic 2 most important things which are asked about the devices. 1, what is the flow rate which we have to keep in the devices, and second, that what FiO2 will be delivered by that device. What is the range of FiO2 which will be delivered by that device? So that is what this question has asked about. The question is about child infant nasal cannula. So question is on nasal cannula. Okay. With a flow rate of 3 liter per minute. So they have asked with a flow rate of 3 liter per minute of oxygen flow. What is the FiO2 which will be delivered? Okay. Now this nasal cannula, what kind of device this is? What kind of oxygen delivering device it is? It is low flow, variable FiO2 delivering device, FiO2 delivering device. So what do I mean by this variable FiO2? I mean by this variable FiO2 that device can give some FiO2 at a particular flow, but this FiO2 which it will be achieved, it will be achieved or not depends upon the breathing pattern of the patient. So in this device, this FiO2 achieved depends on breathing pattern of patient, breathing pattern of patient. So if patient has a higher respiratory rate, more air entrainment, room air entrainment will happen in the device and FiO2 will decrease. What FiO2 it can deliver at this flow also will not be achieved. So that's why it is variable FiO2 delivering device. So let us talk about nasal cannula. Let us stick to the device which has been asked in a question. So as I told you, it is low flow variable FiO2 delivering device. So in this, what is the flow which we keep? We can start with 1 liter and we can go up to 6 liter per minute. Going beyond 6 liter per minute will not give us any added benefit. And what FiO2 it will achieve? It will give us an FiO2 of 0.24 to 0.45 maximum, that is 24 to 45%. So how does this FiO2 will be achieved? It depends upon the flow and it depends upon the patient's breathing pattern, right? Now, very important, how is this calculated in nasal cannula, the FiO2 which it will achieve? For every 1 liter, for every 1 liter per minute of flow, 4% FiO2 will increase above room air, okay. So above room air 4% will increase. So if I am giving 1 liter per minute, what will I achieve? 0.25, right? That is 4% above room air, okay. If I keep the room air 20%, I achieve 0.24. That is 20 plus 4% for 1 liter. So 0.24%, that is 0.24, okay. For 2 liter per minute, similarly 28%. For 3 liter per minute, so how it is calculated? For every liter, 4% FiO2 increases. For 1 liter, 24%. For 2 liter, 28%. For 3 liter, 32%. For maximum 6 liter, 44 to 45%. Okay. So now let us see for 3 liter. So for 3 liter, it will be 32 to maximum 33%. Okay. If I consider 21% as room air, so for 3 liter, if I add 4 into 3, 12. So 21 plus 12, so it comes to be 33%. Or if I add 20 plus 12, it comes to be 32%, right? Okay, so 32 to 33% is what we are expecting at a flow rate of 3 liter per minute. But infant, child, they have a higher respiratory rate. So definitely this calculated FiO2 will be achieved by them or not is little subjective. It cannot be more than this 30-33%. It can be less than 30-33%. It depends upon the breathing pattern of the patient, but it cannot be more than 30-33%. So what are the options in the question? 35%. It is above 33%, so I don't think this should be the answer. 30%, let me keep it. 25%, it is well below. No, it will also not be the answer. 40%, it is well above the 30-33%, so it cannot be the answer. So answer has to be your 30%, right? I'm saying child and infant have a higher respiratory rate than adult. So definitely more dilution. So definitely this 30-33% also may not be achieved. It will be little less than this. So 30% is a reasonable answer. I'm telling you it cannot be more than 33%, right? It can be less, but it cannot be more. So if I am not getting this 32-33% in the option, I would go for the nearest low value, and that has to be 30%. Okay, so this has to be answer. Okay, next question. Very predictable question. Question from pre-anesthetic evaluation. So this question is from the topic pre-anesthetic evaluation. Again, in this topic, I have very well discussed in the app, And I told you 3 important things can be asked about in this topic: ASA classification, Mallampati grading, and pre-anesthetic order. These are the 3 things which are very commonly asked in pre-anesthetic evaluation. And this time the question was on ASA grading. So this ASA grading we do prior to surgery to assess the risk associated with surgery, right? And we, as I already told you, we have 6 classes: ASA grade 1 to 6, okay? And this grading tell us about the risk associated with surgery from 1 to 2, 2 to 3, 3 to 4, 4 to 5, 5 to 6. The risk is gradually increasing. And this is not a uniform grading system. 1 to 4 is one type of grading system. 5 is separate and 6 is separate. Okay, 6 is comatose patient for organ transplantation. 5 is patient in whom surgery is the only option. Surgery is only option for survival, no other thing. And 1 to 4, surgical condition and comorbidity is 2 different things, and we have to see that what risk the comorbidity is presenting on the patient. So what is ASA grade 1? ASA grade 1, healthy patient, that is no comorbidity. So they are healthy patients, just have come to get operated for some surgery, and once it is done, they become disease free. ASA grade 2, mild disease with no limitation. So no limitation. Comorbidity with no limitation. Okay. So mild to moderate systemic disease with no limitation, right? No functional limitation. Between 1 and 2, hardly there is any difference of risk. Now comes 3. ASA grade 3, which has been asked in exam. ASA grade 3, they say moderate to severe disease with moderate functional limitation. Patient is asymptomatic on normal activity. Patient becomes symptomatic on strenuous activity with moderate limitation of the activity. So this is moderate to severe disease with moderate limitation, okay, with moderate limitation. But this is moderate limitation, this is not incapsulating. ASA grade 4, severe incapsulating disease with which is a constant threat on the life of the patient. Okay, ASA grade 5, I told you, is not expected to survive if surgery is not done, right, with or without surgery. ASA grade 6, brain dead or comatose patient for organ transplantation. So let's come back on the question. So patient of class 3 includes mild disease? No, that is class 2. Okay. Moderate disease? Now moderate can be class 2 or class 3. They have not mentioned, right, with what kind of limitation. So let me see. Severe disease, right, and threatened to death. Threatened to death clearly class 4. Okay. So whether class 3 I would go for moderate or severe, we should go for the answer severe with moderate limitation. So severe disease with moderate limitation. No limitation on normal function, but limitation on strenuous function, right? Mild to moderate, mild class 1, no comorbidity. Class 2, mild to moderate. Disease can be described as mild to moderate disease with no limitation, no encapsulation, nothing. Class 3, moderate to severe disease, right, with limitation, okay. And class 4, constant threat on life, So I would go for answer in this question severe, right, as class 3, because moderate is coming in both class 2 and class 1. So I would go for severe as the answer. Okay. So severe would be the answer for class 2. Second question. Next question, again a very expected question. A high flow nasal cannula deliver how many liters of oxygen per minute? So first question was on conventional nasal cannula, that is a low flow device. Now this question is on high flow nasal cannula. This is high flow fixed FiO2 delivering device, fixed FiO2 delivering device, right? So this high flow fixed FiO2 delivering device, right, they are devices which can give a very high flow and which can also give a fixed FiO2. The first question which I discussed, they give variable FiO2 depending upon the effort, breathing pattern of the patient, and this device gives fixed FiO2, okay? So what does high flow device give us? So high flow therapy is oxygen supply system. It's an oxygen delivering device which can give up to 100% oxygen. It can give from FiO2 21 to 100%. So it can give up to 100% humidified heated oxygen at a flow rate up to 60 liter per minute. So it can give flow rate maximum up to 60 liter per minute. We can start with 10 liter per minute, we can start with 5 liter per minute in this device. Definitely, we will always keep it above 10 liter, then only we are putting this device, because otherwise we will use low flow devices. So we start with 10-15 liter per minute and we can maximum go to 60 liter per minute, okay? So it can give up to 60. There are some devices which are coming in high flow devices which can give even more than 60 liter, but maximum HFNC give up to 60 liter per minute. So according to me, the answer has to be 60 liter per minute. So it can give 30 liter, it can give 40 liter, right? So they have asked the maximum in the question, the HFNC deliver maximum how many liters of oxygen per minute? Answer is 60 liter per minute. So what is the benefit of this HFNC, high flow nasal cannula? Now high flow nasal cannula can give high flow, and when the flow we keep a high flow, if patient is requiring a high flow because of his increased inspiratory effort, the contribution of flow will decrease the patient's effort and will make the ease of breathing better. So it will decrease the inspiratory effort of the patient. Then it will give humidified patient, again it will increase the comfort of the patient. It can increase the mucociliary clearance, right, because of heated and humidified gas which we are giving. It is giving high fixed FiO2, so there is no entrainment of room air in this. It will decrease the respiratory rate and it will offer a PEEP, positive end expiratory pressure, because of the positive pressure, and it will help in CO2 washout, right? It will decrease the dead space. So what are the benefit of this high flow nasal cannula? Number one, it can give high flow up to 60 liter per minute. It can give FiO2 up to 100%. It will give heated and humidified gas. So 3 benefits about the device, and because of these benefits, the 4th benefit is it will decrease dead space, right? So it will help in ventilation by CO2 clearance, and it will offer PEEP, positive end expiratory pressure, as you will increase the flow. At 10 liter, some PEEP, at 20 liter, some more PEEP will be offered. So it offers PEEP up to 2 to 4 centimeter of water, and this will improve the oxygenation. So it improves ventilation and it improves oxygenation, because the device can give high flow, fixed FiO2 till 100% and heated and humidified gas. All this benefit has decreased the incidence of intubation in some patient in whom HFNC has been applied at the right time. So this is a very good device, very important device. Okay. Next question, 4th question. Now, child with severe respiratory distress with respiratory rate 90 per minute. All of the following should be done except, right? I mean, what is not to be tried in this child? Well, intubation. If the child has a respiratory rate of 90 per minute, intubation can be an option, but definitely first we will go for non-invasive ventilation, right? Positive pressure ventilation. Yes, the child requires the support of ventilation with such a high respiratory rate and respiratory distress. Okay. Bag and mask ventilation. Definitely we will start with bag and mask ventilation. Then if, let's say, we will support the ventilation by CPAP or something non-invasive ventilation, and if the child will not improve, we will go for intubation. So this child with severe respiratory distress and a respiratory rate 90 per minute needs support in ventilation and needs support in oxygenation, both. So it needs support in ventilation also, in oxygenation also. HFNC would have been a good option in this child, but respiratory rate of 90, I don't know how much HFNC would have supported. But how do we approach in this child? Definitely, initially we can start with oxygen supplementation, but oxygen supplementation with a normal oxygen delivering device which is not supporting the ventilation would further not prove any improvement in this kind of child. It will just let's say waste our time in management. Okay, the child needs support in both ventilation and oxygenation. So fourth option, give oxygen with nasal cannula. This can only help in oxygenation, and that also in mild hypoxemia. So this device, if I will attach, this will not be of much benefit, because it will not give us, it will just waste our precious time in managing this child, because this device will not support the ventilation. Child will get let's say with this such a high respiratory effort, the child will go into negative downhill and further deterioration will happen. So we have to support ventilation. How can we support the ventilation? By bag and mask, yes. By positive pressure ventilation, yes, we will support with positive pressure ventilation, and maybe intubation is required. So all these things can be required in this child with severe respiratory distress. Giving oxygen with nasal cannula, oxygen supplementation is required, but with these devices, with nasal cannula, it would not do us much benefit. So fourth would be the answer, because except has been asked in the question. Okay. Now, so respiratory rate of 90 requires support or assist in ventilation due to increased work of breathing. So this we will always go for NIV, non-invasive ventilation. And if this, how non-invasive ventilation? We can go for bag and mask ventilation. We can start with bag and mask ventilation. We can go for CPAP, right, non-invasive. And if this is not improving, we will go for intubation and mechanical ventilation. We'll have to put on mechanical ventilation. So we need to assist the ventilation in this child. Okay, otherwise more deterioration will happen. Okay, next question. A very simple question, direct question. Pinpoint pupil is seen with, well, so many times I have told you, opioids. Opioids, all the opioids except one produces pinpoint pupil. So opium would be the answer. Direct question, opium would be the answer, right? So let us see the causes of pinpoint pupil. So remember 4 P's of pinpoint pupil. Opioids produces pinpoint pupil. So all opioids except pethidine, that is meperidine, which is like atropine, which has atropine-like structure. Pethidine produces pinpoint pupil. Okay. Pethidine produces mydriasis, not myiasis. Okay. Okay. Then organophosphate produces pinpoint pupil, right? Then pontine hemorrhage produces pinpoint pupil, and then your eye drops, glaucoma eye drops like pilocarpine produces pinpoint pupil. So these 4 P's, that is painkiller, that is opioid, phosphates, that is organophosphate poisoning patient, when they come with a pinpoint pupil. Then pontine hemorrhage, pinpoint pupil. Pilocarpine, that is the glaucoma eye drops, produces pinpoint pupil. Okay. So remember, opium produces pinpoint pupil. Okay. Next question. A child with diaphragmatic hernia, all should be done except. So oxygen by a mask, positive pressure ventilation, intubation, bag and mask ventilation. What should not be done in diaphragmatic hernia? We get a lot of cases of diaphragmatic hernia to get operated, right? To give anesthesia to these kind of patients. What we avoid in these patients? What we should not do? Well, if you see in diaphragmatic hernia, what happens? The stomach content goes into the thoracic cavity and it is pressing the lungs. Okay. So if we will increase their volume, then it will press the lung more. What does this bag and mask ventilation do? When we give bag and mask ventilation, then air goes through your esophageal opening, also through glottic opening, and it goes into the our let's say stomach also, intestine also the air would go, and the air also goes in the respiratory tract through the trachea. Well, the air which goes into the gastrointestinal tract, into the stomach, it will inflate the stomach and the intestine, and these are present in thoracic cavity. They will press the lungs more, and then will increase the hypoxia in the patient. Again, ventilation also becomes very difficult in these patients. So bag and mask ventilation is contraindicated in diaphragmatic hernia. So bag and mask ventilation is contraindicated, right? We always attach oxygen by a mask. We do intubation and then do positive pressure ventilation. But by bag and mask, we never do positive pressure ventilation in diaphragmatic hernia. This is again a very commonly asked question, right? So this you have to remember. This was our 6th question, okay? So these were the 6 questions which is asked, right? And very quickly I will again discuss their answers. 6th question, a child with diaphragmatic hernia, all should be done except bag and mask ventilation. This should not be done. So pinpoint pupil is seen in opium. Then a child with severe respiratory distress with respiratory rate 90 per minute, all of the following should be done except. Well, nasal cannula oxygen supplementation is too little help for this child, so it is not done. Then HFNC, high flow, how many liters of oxygen it will deliver? Maximum 60 liters per minute. Then ASA grade 1 study class 3 includes, ASA grade 3 includes severe disease, right, with moderate limitation. And child or infant nasal cannula with flow rate 3 liters per minute of oxygen flow. What is the FiO2 which will be delivered? 30% should be the answer. Okay. So this is the 6th question which I wanted to discuss with you. I hope you have done all the 6 questions correct. We have discussed all these 6 questions in the app. Hope you get a good result. Thank you.
Good evening, friends. Now we are going to discuss psychiatry call. First question. It is little bit confusing, controversial. This was not well-framed question. So let's discuss. A pregnant female diagnosed case of bipolar disorder with previous history of 4 episodes and no episode for last 1 year, well controlled with lithium 750 milligram. Okay. Now in 3rd trimester, patient came in 3rd trimester. Yes, what is the next management? Ideally, when a patient comes with pregnancy and on lithium, we should monitor the lithium level. And if lithium level is okay, we will not change. But this is not given in the option. They have given option increased dose of lithium, decreased dose of, decreased dose of lithium. Switch to valproate, definitely we will not switch to valproate. Stop the drug, no, we will not stop drug. If we will stop drug, then there may be precipitation of manic symptoms. So we will increase dose. Maudsley NICE guideline says that in 3rd trimester, use of lithium may be problematic because of pharmacokinetics. Increased dose of lithium is required to maintain level during pregnancy as total body water increases. I have discussed in my class that whenever there is hemodynamic change, just like whenever questions are asked on lithium toxicity, you may find that in question they have given that patient is on fasting. Patient is on fasting means blood volume is decreasing, vomiting, diarrhea, and that may lead to precipitation of lithium toxicity. As you know, lithium is having very narrow therapeutic index. Okay, so I have already discussed in my class the last trimester of pregnancy, plasma volume increases. The same dose will lead to low level of serum lithium and manic symptom may precipitate. So in the last trimester, we increase the dose of lithium. Yes, little bit controversy, few places it is said that we should decrease. Yes, we will decrease immediately after delivery. When delivery is there, blood loss would be there, and if we are giving the same dose, then it may precipitate with lithium toxicity. So that's why in this question, I will prefer to mark increased dose of lithium in last trimester. Okay, any doubt, any change in question, you can mention or options. Yes, next is, a patient was started on amitriptyline and was found unconscious. Which of the following does not suggest TCA toxicity? Tricyclic antidepressant, favorite topic. Yes, mechanism of action, you know, inhibit the reuptake of serotonin and norepinephrine. Side effect, we do remember mnemonic HAM, antihistaminic, L1, alpha-1 blockage, M1 blockage. So HAM. जब भी एंटीहिस्टामिनिक होगा, there would be sedation, increased appetite, weight gain would be there. These are side effect. We will remember the symptoms of toxicity by side effect only. Alpha-1 blockage, postural hypotension, M1 blockage, dryness of mouth, mydriasis would be there. So now, other than that, cardiac arrhythmia. That's why in tricyclic antidepressant, when we prescribe, we do monitoring by ECG at the baseline, 7 days after starting, and whenever we increase the dose of TCA. This question has been asked. Now, what is the toxicity? In toxicity, yes, anticholinergic effect. So there may be delirium, altered sensorium, confusion. Yes, you know, delirium is also called acute confusional state. Okay. Hypotension, tissue hypoxia, metabolic acidosis, ECG changes would be there, arrhythmia would be there, hyperthermia would be there, hyperthermia, not hypothermia. Yes. So in this question, arrhythmia, yes, confusion, acute confusional state, pupillary dilation, mydriasis, not hypothermia, hyperthermia. Yes, you may give me hint if you have any, yes, any other option. Do you agree with the option? Yes. Yes, so in this answer is C. Now, a patient started on mood stabilizer, you know, this is a repeat question, developed hyperammonemia. Hyperammonemia is there, hepatic enzymes are increased, yes, without second thought, hyperammonemia, valproate. Okay. Hepatic transaminase may increase with carbamazepine, other drugs also, but hyperammonemia is quite suggestive of valproate. So answer is B. Yes, again this is controversial little bit. Alzheimer's disease does not want to take medicine orally. Don't want to take medicine orally. Which of the following acetylcholinesterase inhibitor can be used? First of all, memantine is not the answer because it is NMDA antagonist. So this is ruled out. Now, rivastigmine is being used as transdermal patch for a long time. And donepezil recently approved as transdermal patch. Means both rivastigmine and donepezil. In this question, if they have given recently approved, recently came, then answer would be donepezil. But yes, if they ask only one, yes, better I will prefer to go with rivastigmine. Okay, because efficacy and tolerability is better with rivastigmine. So it is answer in this question. If same question is repeated, then yes, few students told that option was tacrine. Yes, tacrine. Yes, not. So answer is B. Next question, again repeat question. All the following side effects are more commonly seen with carbamazepine than oxcarbamazepine, except, yes, oxcarbamazepine was introduced with having lesser side effect than carbamazepine, except hyponatremia. Yes, this is straightforward question. Skin side effect, all side effect, blood dyscherias, all these side effects were less in oxcarbamazepine but was having more hyponatremia. Yes. Next question. Yes, this is stages of motivation. Pre-contemplation stage, contemplation stage, planning, action, maintenance and recovery stage. Pre-contemplation stage, suppose a patient is taking alcohol, you ask, what, do you have any problem? He says, no, Dr. Saab, I take only 1 peg of alcohol, 2 peg of alcohol, koi problem nahi, I have no problem. Means denies, denial, it is not a problem, don't want to change the behavior. Contemplation state, patient accept, acknowledge, but he is not sure about that. Okay. Planning will take step, but will take action in action stage. And if patient is not taking for more than 6 months, we will say that patient has maintained this abstinence phase, he is not taking alcohol or substance. And after that, recovery stage. In recovery stage, there is 100% self-control. Self-control means if I am having alcohol in front of me, but I am having self-control, okay, I will not take alcohol, hence I have been recovered. In these stages, from these stages, patient can go at any time into relapse, point it out. So now we solve question, contemplation. A person who smokes is thinking of quitting smoking but not sure. Yes, sahi hai, accept, acknowledge but not sure. So this is true statement. Pre-contemplation stage, patient is considering starting morning walk. In pre-contemplation stage, there is denial. So this is wrong. Maintenance phase, person quit smoking 1 year back and has not smoked since then. Yes, more than 6 months, this is true. Action phase, person with obesity says that he can't do anything as it runs deep in his family. He is denying. So this is not action phase. So false. So answer is statement 1 and 3 are correct. Okay, so this time questions were more and more on pharma, psychopharmacology. So hope session was good. Thank you. Best wishes for your result. Thank you.